All right, so these sessions are recorded. So if you want to go back and look at these, we post them on our pages, on our Facebook pages. Lindsey's going to be running a few minutes late. Next term, she is the School of Medicine SGA president, so she is working a lot of the logistics behind us getting back to the island. My name's Brady Hernandez. We're both term fours. I've just been elected for next term the IEA Honors Society president. So we do like a lot of what the Honor Society does is tutoring. So Lindsey and I like to do these reviews. They are separate. This does not count towards any sort of DES credit, but we like to do them on the weekends. We like to kind of set our own guidelines just because if we do it through school, we can't record them, and there's a lot of things behind that. So we do these separately. So just to let y'all know, this isn't, you don't get any sort of DES credit for this. Okay, let's see. So some of the housekeeping things I want to go through first. Let me share my screen. Your exam is when exactly? Wednesday? Monday?
Tuesday.
Tuesday in between. Okay, cool. So this is your last weekend. So ideally, as you get closer up to the exam, you're doing more practice questions, right? One of the things that's interesting about this is that not only knowing the material, but learning the art of answering these style of questions, right? So there's only one answer that's going to be right. There's no all of the above. There's no A and B. So you need to use the test to your advantage. It's just like playing sports. The more you practice, the better you get at it. The quicker you get, the more confident you get. So the idea is, and the direct correlation to how well you do, the best correlate is how many practice questions you do. So that being said, we format these, at least in the beginning, we format a lot of these reviews as question-based sessions. I'm going to walk through the way I do these with you guys so that y'all could see kind of how my mindset is. On the exam, again, use it to your advantage. Use the highlight function, use the strikeout function. FTM is very buzzword heavy. All right, what does that mean? That means a lot of the diseases you're going to isolate and be able to answer on the test, you're going to find buzzwords for it in there, okay, in the question. Once you get to CPR and stuff down the road, it's a lot more conceptual, a lot more clinically relevant. But as of right now, one step at a time, you're going to notice a lot of buzzwords, okay? Buzzwords are going to key you into what they're talking about. Now, I know the first couple of weeks was dense. They did that on purpose to kind of get you in the mindset of how to do this. But you know, it'll kind of slow down and then kind of get at a steady pace. So your goal right now is to figure out how you learn best, right? A lot of medicine is learning how you learn. Everybody's different. You can get advice from 100 different people and kind of make it work for you. If for some reason something is not working, you don't have to use it. Some people swear on Anki. Kishore is a big, my buddy here, he's big on Anki. He loves it. I don't. It's just not my thing. But if you like it, it's a good way for spaced repetition. Everybody's different. But one thing I can say is it is difficult in this online format to meet people, but when you study with people, it does make it easier. Teach it to each other, just talk through stuff. You know, you find out very quickly where your deficiencies are when you start talking out loud about it. Okay. All right. I think that's all I have for now. When Lindsey gets here, she'll be able to man the chat as we go. It's going to be kind of difficult. I get distracted with the chat open, but she can do that when she gets here. The plan is I'll run through the first couple of weeks. We'll do some questions. We'll hit the high concepts. And then Lindsey's going to do some cumulative questions again at the end. Should run about 2.5 hours. We'll take a break in the middle and go from there. Since I can't monitor the chat as we speak, y'all could just cut me off and ask questions if you want. No big deal. This is informal. All right. Let me share my screen. And we're going to go just show y'all a couple more things. Now, so if you go to the Scrubs page, let's see, you could see I post all the reviews here. I will also post the recording here as well for this review. So if you did not go get these, you can get the slides and annotate them as we go. Also, I wanted to point out, if you look here on the About section, there's a link. The channel is technically private, but if you bookmark this link right here, it'll bring you to this playlist. This is all of the Term 1 playlist. So once we record it, we'll put yours up here. But if you wanted to go ahead and look, we've been doing this a while, so we've got pretty efficient at doing these. You can look at the other term one stuffs we've done. So, but if you subscribe to the channel, it'll say it's empty. You have to have the link. So do that. Okay, now, also on the drive, on my Google Drive, there's a link to it as well. What I do is I post a lot of the stuff that I found helpful, or honestly, anything somebody gave me at the time, I kind of threw it in a folder. So you can go through this, see if anything here you find helpful. You know, some people take a lot of time making these, so it's kind of easier to use somebody else's stuff than making your own at times. So that's all there for you. What I also do, which people have, I do this for all the terms now. I post my consolidated notes. So what I do a couple of days before the exam is I write out shorthand just what I find is super important, stuff I need to burn into my brain before the test. So I've been posting these. So this is just kind of some of the quick and dirty way of doing this. Some of the things I wanted on there. So y'all are welcome to look at that too if you want, but that's there. All right, let us get started. All right, so again, I run Scrubs. Lindsey's on Dog Mom. You can get additional resources. We post that for you guys as we go along. So just a couple of quick things about your schedule. Well, biggest thing is don't fall behind. Whatever you decide to do, my goal is when I start Monday of the next week, everything from the previous week is done. I find it stressful to have stuff carry over, so that's always my goal. If you pre-read, do it in a efficient fashion, maybe 15-20 minutes, because what the teachers are going to point out in lecture is going to be what you want to focus on. So if you're pre-reading and you're focusing, hey Lindsey, you're muted.
What's up? I'm here. I know you missed me.
You want to introduce yourself to our new kids?
Sure. So my name is Lindsey. You've probably seen me post in your Facebook page. I'm a term 4 like Brady. I am currently in Houston, Texas. I'm also going to be the president of SOM Affairs for SGA next term. So if any of you guys are running, you've been talking to me. But I run Dog Mom DES. Just if you ever need anything, just reach out. If I don't, I'm usually pretty responsive unless I have like 10 things going on, and it'll take me a day or two, but I usually try to get back to everyone who reaches out to me about anything. But good luck.
All right, so if you have logistics on going back to the island, feel free to email Lindsey, not me. All right, now again, practice questions, super important. Make sure you do the ones they post. The IMCQs are very representative of how the teachers are going to write their questions. What they write the practice questions on is probably what they find is important. So you should focus on that. Again, if you like Anki, go for it, dive into it, kind of work out the kinks of it, and then you'll be fine. And lastly, first aid. The sooner you get introduced to first aid, it is the review book for the boards. We all use it. It is the Bible. It is the first thing I go to when I need to look up something to see if it's important or not. SGU bases its curriculum on what's important for the boards. This book is used by everyone who studies for the boards. So it's a good way to see what's high yield and what's not. Okay, so you could look at that. It's not going to explain a lot, but it has a bunch of nice tables, a bunch of mnemonics. I've taken some stuff in the review from it that you could see, but the sooner you get to that, you can get a hard copy, but if you get the PDF, you could search stuff. So it's easier to find things. So yeah, start looking into that.
You do, hold on, there's a question in the chat. I'm going to answer for everybody. You do not have that book. It is a supplemental resource. But if you don't have the most current version, don't worry about it. They come out with a new version every single year, but the differences are very minimal. And so, like, for example, I have a 2017 version because I bought it a while ago for, inspiration for myself, and I use that. So if you have an older version, don't think you have to go spend more money to get a new version. Somebody said there's a $30 one on Amazon. Make sure that if you buy it for cheaper, you're buying an actual copy. I had a friend in my term who bought like a $20 one off of Walmart.com or something, and they sent her like a photocopy of first aid. So make make sure that you're paying for a first aid book. It's USMLE first aid, and not like a photocopy sham kind of thing, but it is definitely a lifesaver. So invest.
So just a couple of things you're going to want to focus on the test. You are given 72 seconds per question. I try to keep it to 60 seconds. You have a minute to answer the question. If not, mark the best answer you have, like put the best answer, mark it, and then come back. Reason being is if you get, you run out of time at the end, you don't want to just have to mark the last 5 or 10 questions, right? You want to be able to go back. If you try to cap yourself at 60 seconds, you have 12 extra seconds per question to go back and check it, to go back and check the ones you flagged. I am very methodical when I take tests. I find that to be less stressful. I do everything the same exact way, right? So I highlight things, highlight important words. That way, when I go back and check it, I could just look at the highlighted words. I strike things out. There is something psychologically about being able to see 2 answers opposed to 5. It makes it easier as you go. So a couple of other things, no whiteboard, right? So no scratch paper. The teachers have been very good about this, the professors. So you'll be able to do any sort of math in your head that you need to do. Okay, you do have a calculator. I'm sure y'all have used the ExamSoft platform for your eSoft quizzes. You do have a calculator and stuff like that, and like a little notepad that's electronic, so you can use that. And then just a rule of thumb, when people are stressed, they tend to change their answers. I think historically, at least me, if I change my answer, I tend to change it from right to wrong. So my rule of thumb is when I go back and check the test, I never change an answer unless I'm sure I made a mistake. That's just how it is. So that's a good way to start practicing. What's testable? So, and we're going to try to point these out for you guys, but things that are differences, right? So if they give you 2 separate scenarios, 2 separate diseases, they're all the same except one characteristic. That's the thing you want to highlight, right? So that's the thing that can be tested. They're not going to ask you the 10 things that are the same. They're going to ask you the one that makes them different. So look at big differences. If you look at 5 different proteins and they all fall into one category, but one is on the inner leaflet and the rest are on the outer leaflet, focus on the one that's on the inner leaflet, right? Because they're looking for these single differences. All right, as always, you want to start clinically. All of these vignette style questions are going to be clinically relevant. A blah, blah, blah year old patient comes in with blah, 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 right? So a good practice is to start with the clinical scenario and then work backwards. This is the presentation. This is the genetic defect. These are the symptoms, and break it down like that. So whenever you see something clinical, you need to start the slide. That is going to be important. Yeah, being able to differentiate diseases for sure. And then Sakai questions. Those are going to be another good representation of the test. Again, no right way to answer questions. You just have to do it. Some people, I read the whole thing. I kind of act like somebody's walking into the office. I get a picture of what's going on. Some people read the answers first. Sometimes I take a peek to see what they're looking at, looking for me to answer. Some people read the last line, like what the question is. That's beneficial in FTM sometimes, just because they'll give you some silly scenario and then just ask you one question at the end. Whatever works for you, you'll be fine, but eventually you're going to just have to start reading from top to bottom. So if you can do that, go for it. Maybe if you get crunched for time, then you could start reading the last line, the last question. But again, there's really no right way to do it. Whatever works for you. All right, we're going to start off with some fairly straightforward ones, but a lot of these aren't exactly intuitive. So let's go with this. What you can do is private message Lindsey or me with your answers, and then we'll go through these. So these aren't exactly vignette style, but we're just going to start working on some of the high yield concepts. Yeah. Good, good. And again, we have strategically selected these questions. So take that take that as it is. These have been seen before. All right, so cool, right? So primary cilia and cilia respectively. So the primary cilia is going to be 9 plus 0. Cilia is going to be 9 plus 2. So if we look at these, the primary cilia is 9 plus 0 arrangement. That's the base of the cilia, the kind of the anchor point. And the cilia is going to be a 9 plus 2 arrangement. You see this right here is the 9 triplets at the base. And that's going to be your primary cilia, and then 9 plus 2 up here. 9 doublets, but plus 2 singlets. So if you want, you need to start getting the terminology down. Another good thing to start doing is when you see these Latin-derived words, to start look them up real quick and start jotting down. The more you do that, the better you'll get at just breaking down words into what they mean, into their Latin derivatives. All right, so we're looking at this 9 plus 2 microtubule arrangement. See this little EM picture right here? I would make note of that. That's been seen, but you could see these 9 doublets plus 2 singlets in the middle. Those are microtubules. And then at the base, you see the 9 triplets plus nothing in the middle. So again, not exactly super clinically relevant, but there are some diseases that y'all are going to touch on that have to do with genetic abnormalities with this. All right, try this one. And y'all will get better at looking at these histological images too, and kind of differentiating with time. It's just practice. All right, so what are we looking at here? You could see the cells here, this hyperchromatic nuclei in here, but we're talking about this little pigmentation right here, this reddish brown pigment that is known as lipofusion, right? This happens with age, so you tend to see these in older people. So again, a lot of times, even I do it, I skip over the age a lot of times when I'm reading these vignettes, but if I had a picture like this, I would say, that they may be lipofusion. Let me go back and it'll say like a 70-year-old patient. So you can use the age as like a defining characteristic, primarily if they're very old or very young, because those tend to delineate ages or different disease states, being young or old, and then in the middle, obviously. So yeah, lipofusion is that wear and tear pigment. Hemosiderin is based around iron. You can get these deposits with a lot of hemolysis or red blood cell lysing or breaking. Melanin is what you have in your skin that makes you, that kind of pigments your skin. Glycogen is formed, it's the sugar form, and then you have lipid primarily in diseases. So they're just kind of introducing you to some of these things. One of the difficult things I found with FTM is you're kind of bombarded with stuff from all around. It's not like specifically cardio or respiratory or renal, right? It's like everything's all over, but it gets easier as you go. They kind of need to build your foundation first. Make sure you get these, this foundation done, and then you start to build the house, right? Okay. Look at this picture. Hopefully y'all have seen this before. For some reason, this always comes up. I don't know, somebody likes the way it looks, but yeah, so what are we talking about here? Yeah, exactly, right? So pinocytosis, you could see the little arrows, these little circles. So pinocytosis means cell drinking, cytosis, cell, pino drinking, right? So you could see these little circles here. It's just, it's pulling up little vacuoles of fluid, right? So again, snap a picture in your mind of whatever this looks like, because if it comes up, you'll see it. Yeah, so they're, so the point is that they're pointing to these little arrows right here. They're pointing to these little, that's all you need to focus on right now. Yeah. Okay, so cholesterol. What is important about cholesterol in the membrane? Again, these are more definition type stuff. Oh, while we're talking about this, let me point this out too. I know a good bit of term twos are here for the BSc review. Thanks for coming. For you guys, I didn't find FTM1 too high yield on the BSCE. For you, those of you that don't know what that is, that's the cumulative exam you take after term 2. For the term 2s, I would focus mostly on the genetic stuff. If you see anything here that has come up multiple times, cystic fibrosis, stuff like that, focus on that. I don't remember, Lindsey, do you remember any math? I don't remember too much math on the BSCE.
I don't remember any math on the
Any
BSA.
math, no real drugs, because y'all get that in term 4. So y'all
Maybe
just
like
focus.
one, but
Yeah, oh, you know what? Maybe like they did steady state for half-lives, obviously 4
yeah.
half-lives for that. So y'all know that. But other than that, focus on like the genetic stuff we'll do at the end. Okay, so cholesterol, what does it do? It stiffens the membrane at body temperature. It's going to stiffen the membrane. So it's going to decrease fluidity, which in itself will decrease permeability, right? If you put this big block of cholesterol in this fluid membrane, it's going to stiffen it. Now, it does vary based on temperature. I think I have a slide on it. This just kind of, you're going to get into cholesterol much more later. But we're just going to touch on it now. But for what you need to know right now, it's going to stiffen the membrane. If you see here, so the membrane is fluid with these phospholipid bilayers. So when you put these huge cholesterol molecules in there, it tends to stiffen it and also decrease the permeability. But if at low and high temperatures, it does the opposite. So at very cold temperatures, you would expect the membrane to be stiff. So the cholesterol is going to make it a little more fluid. At very hot temperatures, you would expect the membrane to be very fluid. Cholesterol is going to stiffen it. But I don't think they would go that deep into your exam on that. I think you would just need to know at basal body temperature, it tends to stiffen it. Okay, it is made. Bile acids are made from it. Also steroid hormones. So. But y'all will get into that later. This is just what I just elaborated on with high and low temperatures, but just in a general sense, cholesterol is going to tend to stiffen the membrane. That's what you need to know.
I'm getting some questions in the chat. Cholesterol is going to make the membrane more fluid at colder temperatures, and it's going to make it more stiff at increased temperatures, because, you know, just think about water. When it's cold, it freezes. When it's hot, it vaporizes. And so in the cell membrane, depending on the temperature, the phospholipids are going to change. And so the cholesterol is in there to maintain stability both at cold temperatures and increased temperatures. So the overall idea is the stabilization of the membrane at temperatures. That's the main idea there. That's why you care about cholesterol in the membrane.
Yeah, so I'm sorry if I confused you guys. So just remember, at body temperature, it's going to tend to stiffen it. But if you look here, it's going to be, if the temperatures are far away from body temperature, it's going to be a corrective response. Okay, so at very cold temperatures, the membrane is going to be a bit too stiff. It's cold, right? So the cholesterol is going to tend to make it a little bit more fluid. At hot temperatures, it's going to be very active, the membrane. So the corrective response cholesterol is going to make it a little stiff. So you want to keep it pretty much stable. So cholesterol will help. Yeah, you could think of it like a buffer. Excuse me. Yeah, it'll keep it kind of at where it needs to be. I'd be surprised if they went into this much detail. They may have in Sakai, but just in general sense, it's going to stiffen the membrane. Okay. Y'all are going to talk about, well, let's answer this question first, and then we'll talk about it. This is more of the vignette style question we're talking about. All right. 2-year-old, right? Okay, very young. 2 days, acute onset, productive cough, okay? History of upper respiratory tract infections in a young kid. Maybe genetic cause, I don't know, right? Immune system's not built up yet. Let's see, low height and weight, okay, some sort of GI problem maybe. For age, bulky, foul-smelling stools. This, if you see this, means that there's fat in the stools. That's typically what that means. So this is characteristic for, does anybody know? Cystic fibrosis, right, exactly. So the screening test, and again, y'all are going to talk about this a lot, but this is just an intro for it. The screening test, what you'll see is this sweat test, okay? When a lot of parents say when they kiss the child's forehead, it tastes salty, right? So what they use clinically is this sweat test, and that'll tell you. Then they could go in and do DNA analysis and stuff like that. But what actually happens in cystic fibrosis is these channels, or these CFTR, cystic fibrosis transmembrane receptors, CTFR, yeah. are messed up. So what happens is chloride can't properly go across the membrane. So this messes up your concentration. If chloride can't go, sodium can't go, and wherever sodium goes, water's going to follow. So with these kids, a lot of times they have respiratory problems because mucus builds up, because the end goal is to have water there to get rid of the mucus. So if chloride can't go, sodium won't go, therefore water can't go. Okay, so actually on the skin, the membrane is flipped. So, excuse me, the receptor is flipped. So a lot of the chloride that is on the skin that's supposed to get back in, that you're supposed to keep, stays on the outside of the skin. Therefore, they could do this sweat test and just check the skin of the child and see that there's a lot of chloride. Again, I don't want to go into too much detail because y'all are going to talk about this a bunch, but that's kind of the idea. Anytime you have problems with flux of some sort of charged ion, remember chloride is negative. If you pull a negative out, sodium's positive, the sodium could come out. And again, you're always going to want to remember wherever sodium goes, water's going to follow. Okay, so we have this differential there, and because you don't have this fluid, this water there, a lot of times you get mucus buildup, the pancreas, the lungs, stuff like that. Okay, so just introducing y'all to this. And you could see this here. This is from your notes, the CFTR, transmembrane receptor. So
I'm going to cut in real quick, Brady. I'm getting a lot of private messages, and you guys feel free to private message me. I'm trying to answer all of them, but if you have just like a general content question, feel free to blast that to everyone, because peer-to-peer learning is really important. And so somebody in your class might be able to answer it before I can answer it. So I'm just getting a lot of messages, and I want to make sure that you guys are getting your questions answered. And sometimes the best way to get a question answered quickly is having one of your classmates answer it for you. So I'm getting through them. Just start asking your classmates so you guys can collaborate.
Just put it in the general chat. That's fine. No big deal. And y'all can always cut me off too. Again, this is informal, so no big deal. All right, again, so we're seeing the clinical correlate here is cystic fibrosis. What's the problem? Genetic problem with the cystic fibrosis transmembrane receptor. What is the problem that happens from this? You get a lot of chloride buildup, whether it be on the skin or inside the body. What does that mean? Well, if you have chloride, then that can't go across the membrane. Sodium can't go, therefore water can't go. What does this mean? You're going to get a lot of mucus buildup, mucus plugs. This is a conduit for infections. This is a great way for the GI tract can't properly work because you can't get the enzymes in the proper place. Again, I'm just trying to lay it out for you, but y'all are going to touch on this a bunch. So that's just the whole concept between cystic fibrosis. All right, let's try this one.
Gunnar says hi.
All right, so premature child. With preemies, we're always worried about respiratory distress. One of the things that matures as a fetus is the lungs is a big thing. You get this thing called surfactant, okay? Again, y'all briefly touch on this now. I'll get into it a lot more later. But this surfactant is important to keep the alveoli open, to keep these sacs open to so that air can properly transfuse across the membrane. So when in doubt, always go with the longest answer. I'm just kidding, but that is the right answer. This is the long name for the surfactant molecule. You know, honestly, when I do these, like I just try to remember these, because if I remember this and I look at this word, I could kind of break it down. Okay, so I don't know if that works for y'all, but trying to remember this, it's like if I see this, if I know it's this and I see this in the stem or in the questions, I could pick it out, right? So sometimes, yeah, oh, sorry. So, okay, so yeah, so the CFTR protein, yeah, you're correct. It doesn't go into the lumen. That's why the mucus builds up intracellularly. So you can't get it out, but yeah, that's correct. I should probably close the chat for now. Yeah. So anyway, so yeah, so this is the long name for surfactant, but I try to remember this, and then I could kind of pick this out. It makes it easier on your brain, I promise. So again, surfactant here, these little yellow molecules here are going to help to keep this keep this pressure open, right? Because you got a lot of pressure trying to close the alveoli. So the surfactant will keep it open. By doing that, air can get across, air can exchange. Again, y'all will get into that more detail, but I wanted to point that out. All right, essential fatty acids. Essential means you need to get it in your diet, okay? You can't make it. So the essential fatty acids we talk about primarily are linoleic acid and linolenic acid. Now I'm gonna show y'all a trick for this because nobody can ever remember which one's omega-6 and which one's omega-3. If you start counting at the last letter, 1, 2, 3, 4, 5, 6, you find the N. Linoleic acid is omega-6. Linolenic is 1, 2, 3. You find the N, it's omega-3. Yay, there you go. Somebody, we're learning today, people. All right, good. So anyway, so now you'll know that. And but these are primarily these precursors that we need to get in our diet. From there, we could make our building blocks, our amino acids, stuff like that. So I just wanted to point that out. Remember arachidonic acid, arac is like a spider, so it's omega-6, right? It breaks down that way. But if you could break those down, DHA, stuff like that, you'll be good to go. This is a good way to break it down. I know y'all had that long DLA on lipids. No fun, but you kind of need to know a little. If you have a good definition for what's what, you should be fine on the test. Again, DPPC is a good clinical correlate for surfactant, so that's something good to know. Sphingomyelin is what they use, what is used to make the myelin around the nerves, right? So that you can, so that the impulse and the electrical impulse can properly go down the nerve. So those are some good things. If you can look at this and kind of pick out some of the clinically relevant stuff, you should be good to go. But definitely knowing what falls in what category is a good way of understanding it. Unsaturated, polyunsaturated are going to be omega-6 and omega-3. Okay. So again, it gets better, it gets more clinical, it gets more like, what am I going to do when I'm a doctor type stuff. Right now, we just have to kind of lay this down. All right, now everybody's favorite. Let's do some math. All right. So, right. First thing here, okay. So we're gonna have our two compartments, right? First thing, we have to have everything in milliosmolar, right? Everything is not in milliosmolar. What this means is the ionic components have to be separated to make it milliosmolar. So 150 millimoles of sodium chloride is going to be, actually, let me give you all a chance to do this, and then we're going to look at it on the next slide, but I'm going to give you all a chance. You can use paper if you want, but again, remember, you're not going to have it on the exam.
Yes, we will post this recording afterwards and a link to all of the resources we've been using.
Yeah, I'm sorry if I go fast. Y'all just need to tell me to slow down. It's just a lot of material. I don't want to have to keep y'all too long.
Brady, I have a quick question.
Yeah.
Do we need to know that ratio for the lung surfactant, like the?
Yeah, I mean, good to know. 2-to-1 ratio of lecithin to sphingomyelin. Yeah, so lecithin is the DPPC to sphingomyelin. Yeah, I mean, good to know. You'll get into it again when you get to pulmonary at the end of this term. But yeah, that's what they look for clinically. About 26 weeks of gestation, you have this 2-to-1 ratio of a lecithin to sphingomyelin, and that kind of says, okay, the baby's lungs are going to be fine. Start making about 20 weeks, you're good about 26 weeks. That's actually what they consider the cutoff for premature babies, and that's why is because of they're worried about the lungs. Yeah, but that's a good point. No worries. All right, so let's look at this one, isotonic and hyperosmotic. Okay, so let's look at the next slide. Okay, so we're going to do this very methodically, okay? Osmolarity is going to do everything. Whenever they say transiently, you want to take a snap picture of what you have right there, because eventually some stuff is going to cross the membrane to where it gets to a point where all of that product is equilibrated across the membrane. Stuff that's going to do that is stuff that is non-charged, stuff like urea, glucose, glycerol. So if they ever put that in there, that's the stuff that's eventually going to cross and equilibrate. So the things like that, these are going to be components of our osmolarity. What is it transiently? What is it the second you're looking at it, right? But eventually, once we figure out our transient or our osmolarity, once all this crosses over equally, then we're going to worry about tonicity. These are the things that do not cross, things that are charged, okay? Things like our ion components. Now, so let's do this. So first rule, we're going to change everything to milliosmolar. Remember, it said 150 millimolars of sodium chloride. If it says millimolars, has to be changed to milliosmoles. And the reason is because you have to break this components apart, okay? So 150 millimoles is 150 milliosmoles of each ionic component, okay? So this means we're going to have 150 milliosmoles of sodium, 150 milliosmoles of chloride, and they told us transiently we have 300 milliosmoles of urea, okay? Now, on the other side, we had to do the same thing. We have to change millimoles to milliosmoles, which means you separate the ionic components, okay? So you're gonna have 150 milliosmoles of potassium, 150 of chloride, and we see that here. So I imagine they will give it to you in millimolars and expect you to change it. So make sure you do that first. That's rule number one. All right, now we know everything is where it is, so we want to figure out osmolarity. This is transiently. This is before anything is allowed to cross. Now, if we add things up, we have 600 on this side, right? 300 plus 150 plus 150, and 300 on this side. Now, transiently, what does that mean? Water is going to want to go to the place that is has the most ions in it, the most particles in it, right? So water is going to want to equilibrate. So another way of saying that is water is going to want to go to the area of higher osmolarity. This side has more particles, so water wants to go to the side with more particles, okay? This side has a higher osmolarity. So water is going to want to go to that side. At the end of the day, water wants to make everything equal. So these ions these particles over here are going to pull the water that way. Okay, it's going to go to the side with the higher number of particles. Okay, so then I forgot what the question was. It was saying, oh, here we go. So A is hyperosmotic. If you think osmotic is particles, if you think of it like that, right? Hyper means more particles. So A has more particles than B, hyperosmotic. Cool, right? All right, now that's osmolarity. So we'll put an O for that, equals. I'll change the color, and now let's say, okay, so we've given the urea time to cross over. We said urea is going to cross. So now we're going to have 150 particles of urea on each side. That's fine. So we're not worried about urea anymore. So we're worried about tonicity. What does not cross? Now, so that means we have 300, 150 of sodium, 150 of chloride, 300 on this side. We're not worried about the urea, it's already crossed, and 300 on this side. What does that mean? Well, that means it's isotonic, right? 300 and 300. Water's not going to cross. Everything's the same. All right, that's about as difficult as I think they'll make it for you. Just remember, first rule is to split the ions, get it as the milliosmoles, do osmolarity, figure out which side is hyperosmotic, right? That's the side water's going to go to, and then figure out the tonicity, the stuff that's not going to cross. Now, obviously, if water's going to go, they could actually say like B was a cell. What if B was a cell and we had this? What's going to happen to the cell transiently? Anybody? Y'all can speak up.
Wouldn't it
right?
slow?
Well, if B's the cell and water's going to go outside the cell, then B is going to shrink,
Yeah.
right? Shrink, right? So B is going to shrink because water is leaving the cell. So they could, instead of giving you compartments, they could give you one's a cell, one's outside the cell. So again, A is hyperosmotic, so it's going to pull water out. You're going to use these words like hyperosmotic, hypoosmotic a lot when you talk about fluid volumes. So just remember, osmotic is relating to the particles in solution, and then hyper meaning more, right? So if B was a cell, again, transiently, the cell's going to shrink, but then what's going to happen? It's isotonic, so then the cell's going to go back to its normal position, normal state, once the urea crosses over, okay?
So remember that osmolarity is the moment like a red blood cell is dropped into the solution. It is at that moment, nothing has equilibrated. Over time, if something can cross the membrane, then you can take it out of the equation. Essentially, you're taking it out of the equation. So then the only thing you're looking at are the non-permeable solutes.
Right. And again, they could make one a cell, one not. If the cell goes, if water goes into the cell, if the cell is hyperosmotic or hypertonic, water is going to go into the cell because the cell has more particles. If it does that, the cell could swell, the cell could lyse. All right. Hope that made sense, guys. All right. This is just for completeness sake. Now they can put, a lot of times they put sugar in water. They can cut the saline in half, depending on the fluid levels of the patient. What is considered normal is 0.9% saline. That is what our body's at, right? You don't want to give, typically you don't want to give a patient pure water because that can mess up the cells. What would happen to the cells? Water goes into the cells, right? If you give them pure water, the cells are going to be hyperosmotic or hypertonic to the pure water, right? So water's going to go into the cells are going to get bigger. So what you want to do classically, what they do in the hospital, they give 0.9% saline, okay? And that's going to keep everything normalized. You're just going to increase the fluid volume. Okay, so I don't think y'all need to go too deep into this, but just kind of know that 0.9 is normalized, 0.45 is half of that. But I just wanted to put this in here because completeness sake. All right, let's look at this one.
Quick question, Brady. If it was CaCl2, would that be considered 3 particles or 2?
It is. It is 3.
So
yeah,
yeah, 50 mLs would be 150 milliosmoles.
Exactly. Yeah. Let me just. That's a good point. So CaCl2, if they give you millimoles, let's say 10 millimoles of this CaCl2, you have to break this up into 3. I don't think they give you that on the test, but it would be CaCl and Cl. So it'd be 10, 10, and 10, right? All the ions have to be separated.
Cool, thank you. It was a practice question, so.
Okay, yeah, no worries. Thanks for pointing that out. All right, so look, this is your classic action potential. So what happens? Our baseline is right around -70. That's where the cell sits, just the way it's formatted with the sodium primarily outside, with the potassium primarily inside. The concentrations at equilibrium, we sit around -70, okay? So what happens is that sodium channels start to go in, right, inside the cell. At right about this point, -60, -50, you hit threshold and all of the sodium channels open. So B, so highest sodium and conductance will be B. Now, once you get up here to +40, those sodium channels will close, the potassium channels will open, potassium will then flood out of the cell. Remember, sodium starts outside. When you open the channels, it rushes in. This is that depolarization phase. When at this point, the sodium channels close, potassium channels open, potassium's primarily inside the cell, so it's gonna flood out. This is that repolarization phase. D is considered this hyperpolarization, and then you get back to E. So the largest flux of sodium into the cell is B. and the largest flux of potassium outside of the cell will be C. So this is classic. Y'all get to this, y'all see this again and again. And you can see that here. You have this little graded depolarization until you hit threshold. Sodium rushes in, potassium channels open, potassium rushes out. And we sit about -60, -70. I think it's 62, but it is -60. -60 is what we consider standard resting membrane potential. And we'll talk about that in a second. All right, try this one. I'm sorry if y'all hear that. Yeah, that's my dog snoring. She does not like math either, so she's over there snoring, so forgive her. I'll wake her up and introduce y'all later. And so you guys know, the boards always gives you normal values. So some of the ones you'll see often, you could try to memorize because it's just faster. But the board does give you what the normal values are, so they're supposed to give them to you on the test. So you could see if there's any sort of problem with the components. But let's take a look at this one. All right. So what they're telling you here is this is all normal, okay? So our normal membrane potential is going to sit at -60. That's what they're telling you. But they gave it to you anyway. I think this was a Sakai or a question. I don't remember, but it's a good teaching point. So the point is you get 120 millivolts of influx. Now let's work it out. However, you need to remember this. You just need to remember it. I think somebody told me a way you can do it is like positive and positive repel each other, right? So you're going to efflux, whereas positive and negative attract each other. So it's more of an influx. If that helps you, whatever you need to do to remember this. So let's talk about this. So -60. So what we're asking for is, what is the driving force? Now, I think this is the way I try to remember it. So if you think of driving force, if I have 10 here and 9 here, right? The driving force, an arrow is going to represent like the strength of the force, right? There's just one ion, well, let's say 8, right? So one ion is going to want to cross. It's a small force, right? This arrow. But let's say we had 1,000 on one side and 10 on the other side. This driving force is very strong, right? As soon as you open that gate, a lot of ions are going to flux. What does this mean? This correlates to an electrical impulse, right? All electricity is ion exchange. So you can imagine this is going to have a weak driving force, whereas this is going to have a stronger driving force. Now, because of the normalized concentrations of what's inside the cell and what's outside the cell, it's going to determine the strength of the driving force. Some driving force is going to go in the cell. Some driving force is going to go out of the cell. This is going to equal at the end of the day to -60. All right. What does that tell you? Well, primarily because potassium is what's inside the cell, right? That this potassium flux out of the cell means a lot because it's holding it at a negative value. Okay, let me explain that again. So let's say this line is our sodium flux and everything, but primarily sodium into the cell. And this is our potassium flux, sodium, potassium, okay? Now, if we use this concept here, where the ions are inside and outside of the cell, potassium, the concentration inside the cell that's going out of the cell, is going to be much stronger than the sodium and the chloride going into the cell. So potassium is going to be our main component to keeping this at resting membrane potential. But that's what this means. This driving force is what is the electrical impulse we're getting from these ions exchanging. Okay, so if they ask you what's the most important component, it's potassium. Why? Because it's holding it down here at -60. If it was just potassium, it would be -83, I believe. So you can see how close it is to actually being pure potassium. Okay, the membrane's at -60. So all we're saying is, what is the overall charge of the cell? The overall charge is kind of close to what potassium is. Okay. Now, how does this correlate clinically? Well, if you have differences in potassium, like hyperkalemia or hypokalemia, what that means is you're going to have a lot of problems, right? Intracellularly, extracellularly, with conductance. You can get cardiac arrhythmias, problems with your heart rate, stuff like that. So this is just kind of how I understand it. But just keep in mind that this driving force has to do with the amount of ions that go in direction, and it correlates to electricity. This electrical at resting membrane stands at -60. That means potassium is the main player because it's what's inside the cell, and negative would correlate to inside. Okay, that's a little bit much, but that's kind of the rationale behind it. So if we look at our driving force equation, we look at our membrane minus our, what does this stand for? The equilibrium, the equilibrium potential. Or so -60 is going to be where our membrane stands at. And then we are asking sodium. Sodium is going to be, and they gave it to us, is 60. So -60, yeah. Minus, right, which is a plus. Hold on, -60. That's -60, but that should be minus. Hold on, why? Oh, sorry guys, it's been a while. Let me make sure I tell y'all this correctly. This has to be -60. Oh, that's right. It's because it's minus. Sorry. Okay, yeah. Right. So -60 is going to correlate to this, right? Minus a +60, which is this. So -60 minus 60 is -120. Okay, so that works out. Now, why is this positive and not negative? Okay, and that's because it's an influx. We're looking at a negative number, that's an anion. The driving force ends up being positive, right? Because sodium is a cation, right? And our driving force, sorry, I shouldn't have circled that. Our driving force is negative. Let me explain that again for y'all. Hold on. So our driving force is -120. Okay, so that means why is it doing this? Our driving force is negative. Sodium is a cation, right? So we have a cation. Okay, so driving force is negative. Sodium is a cation, which means it's going to be an influx. Okay, I'll explain that again. Now, we're talking about sodium. It tells you that sodium is going to be a +60. That's going to correlate to our EM. It's potassium, not sodium. Sodium here. Okay, yeah.
Brady, I think that the RT over F is just giving us like the value for the Nernst equation. We have to do the log of in over out. So it's like,
yeah, it correlates to the same thing.
Oh, okay.
It's the same thing. They may have not told y'all this, but that correlates to the Nernst equation. So I have a slide coming up giving you the normalized values of it. But if you remember the normal values for the Nernst equation, you'll be fine. But yeah, this equals 60, +60. And so that's why sodium is going to be, this is basically just telling you that the Nernst equation is normalized, but you can get that from these numbers here. So the EM for sodium is going to be positive 60. And then the driving force they gave you is, or sorry, the VM is going to be negative 60. So negative 60 minus 60 is negative 120. What are we dealing with? A cation. What is our driving force? It's negative. So saying a negative 120 is the same thing as saying a positive 120 of influx. Okay, so that was the teaching point I wanted to get to. I know it's a little confusing, but the reason there are no negative numbers here is because in this situation, using this chart, the influx correlates to it being negative. So a positive 120 of influx is the same thing as saying a negative 120. All right. Now, what we're talking about here, that Nernst equation, and this is the same thing as the RT over F. So if you remember, the sodium is going to be standard at 60. Potassium is going to be standard at negative 83. So remember, we said our membrane is going to sit at negative 60. Look how close it is to potassium, right? That means that driving force of potassium, that arrow we make, right? Potassium in to potassium out. This is a huge arrow. This is a huge amount of electricity because look how close it is, okay? That means that's why you get clinically significant effects when you have just small fluxes in potassium in the patient. Cardiac arrhythmias, a lot of fluid volume discrepancies, okay? So you wanna remember these values for the test, primarily sodium and potassium. Those are our major players. Calcium's there and chloride's there as well. Now you may ask yourself, why is chloride negative if it's outside the cell? It's because it has a negative charge, so it flips it. Okay, I don't know if they'll get into that in that much detail with you, but potassium is inside the cell. That's why it's negative. The other three are outside the cell, so you would expect them to be positive. But since chloride has a negative charge, it's going to be negative as well. So that's why that's that. But if you remember these, you can go back and see these are the equilibrium. So you can go back and fill them in here, and they should give you the membrane. Okay, if they say it's standard's negative 60, right? So we said negative 60 membrane potential minus the equilibrium potential, which is negative 6, which is 60. So you subtract a positive 60, negative 120. Negative 120 is the same thing as saying a positive 120 of influx. Okay.
Brady, can I ask a question?
Yeah, for sure.
So when we have the, let's say in that action potential schematic you gave us, when we have the greatest conductance, let's say for sodium, does that mean we have the, at that point, we would have the lowest driving force?
Highest driving force.
Because I did a practice question before I found, and like basically it was interchangeable. So like it showed sodium's max conductance. So basically if it was making up the most of all the fractional conductances at that point of the action potential to make up the membrane potential, right? That would mean that at that point there is zero flux of sodium, right? Once it comprises of most of the fractional conductances.
Well, so
sorry, yeah, go on.
Yes, so technically if you left these channels open, the sodium would flux out to where it would get to zero, right? We have a flip here, but if you think of 3, if you think of at 0.3 versus right here, there's more sodium outside than inside. Yeah. Right here, and it's continuing to go. So as you go, you're getting closer to 0 for sodium, right? So right here, so 2's talking about this part, but right here's higher driving force, right here's a little bit less, here's a little bit less, here's a little bit less, because we're getting closer to 0.
Yeah.
Okay, so, and then same thing for potassium. As soon as these open, you have the largest driving force at the point they open. You open the channels and they're shooting out until it eventually it's going to reach 0. So the more ions you have across, the higher the driving force. Now, again, we don't let it get all the way to 0 because the channels are set to close and the other one's open. So it keeps this gradient here. But yeah, no, so it'll go, the highest driving force is going to be the point where there's the most ions on one side versus the least on the other side.
So that would mean that they're not interchangeable. So conductance and driving force are not interchangeable. So like they're not, when one goes up, one goes down.
No, so they should correlate. No, the driving force, the higher the conductance, the higher the driving force.
Okay, because I thought that because the membrane potential, if you have the highest fractional conductance, that means that specific ion has the least flux. So if that's the least flux, then that'd make it the most driving force.
No, the highest driving force correlates to the highest conductance, but you have to watch the charge too. Maybe that was the problem with the equation, is that if the charges are different, it matters which way it's going through the cell. Yeah, it's probably a little bit more detailed, but thank you for asking. Then we need to get into. But yeah, the higher the driving force, the higher the conductance. Just because, yeah, that's the most electricity that's going to go across.
Perfect.
Okay, so yeah, no worries. So the main thing I want to point out here, what do you fill in for these variables here? How do you get one positive 120 of influx from a negative 120? Okay, so just one of those things. It's no fun. No patient's going to come into your office asking you what their driving force is. Okay, so know these numbers, primarily these two, and you'll be good to go. Opposites attract, efflux, influx. Remember though, they're talking about from inside the cell, obviously efflux and influx. If you could do this, you should be good. Again, the teachers know you don't have a whiteboard, so they, at least for us, they made the math pretty straightforward. All right, so embryology. I don't know anybody that likes embryology. It's probably made up. Somebody got drunk and made it up one night. We used to be toads or something in the womb. I don't know. It's a bunch of fake words. But anyway, the main thing you need to know about embryology is that it is the clinically relevant stuff. What goes on if something happens incorrectly? Okay, so we're going to kind of touch on it here, but as you go and you're like, this is a crazy lecture, it doesn't make sense, focus on the clinically relevant stuff. Why is there a hole in the heart? Why does the patient present the way they do? Okay, so that's embryology. All right, so
just gonna interject real quick. For term 1, embryology is very, very, very minimal. And what we stress to you is probably what you should focus on. We will let you know how to approach the big embryology lectures. So when you get to MSK, that's when you're going to hit embryology harder, but we will let you know how it's been successful for us, because going through each individual slide is not the best. So we will let you know. Just know for term 1, don't stress about it that much. Definitely don't underestimate it. You will have a few questions from it, but don't try to memorize every single little thing from the embryology lectures, because when you get to the exam, you're going to notice that they focus on like a couple different things. So please don't stress yourself out about it.
Yeah, so the clinically relevant stuff tends to be at the end of the lectures, right? They'll give you a bunch of precursors to what's going on, a bunch of crazy definitions, then they'll give you the clinical stuff. Focus on the clinical stuff, ask yourself what happened wrong. As long as you know that, you should be good. So when we talk about trophoblasts, or which layer of the trophoblast, pregnancy test, this is what they check for, HCG or beta HCG in the urine, okay? This comes from your sessiotrophoblasts. All right, practice saying these words and you get better at it. Cytotrophoblast is going to be your cellular layer. You will sound silly for about 2 years, and then you get used to it. So have fun in small group. All right, so yes, beta HCG, that's what it's called, sessiotrophoblasts. And yeah, so this is very busy. Yeah, it's one of those things. Just kind of remember, endoderm is inside, right? So you're thinking about like inside of the vessel, stuff like that. Mesoderm is kind of in the middle, and then ectoderm is outside your skin and stuff like that. Some things you want to focus on now. What happens in the beginning? You get this inner cell mass, makes the embryo. Mesoderm, you're thinking about some of these larger heart structures, right? Or these larger organ structures. And then the main thing that we want to talk about, neural crest cells. When in doubt on the exam, the answer is always neural crest cells. Why? Because they like neural crest cells. It's very strange why all this stuff comes from neural crest cells, but they do. So they like to ask about this stuff that goes wrong. You'll hear with failure of migration of the neural crest cells. It presents a number of problems, but I'm just introducing you to this. I wouldn't like go whiteboard this whole thing out. I just want you to have a general understanding of what comes from what. We just talked about the endothelial. That's going to produce your beta HCG. Y'all will get into later. This keeps the womb viable for pregnancy. All right, now some pictures. What are we talking about here? Yeah, right, good. So hemidesmosomes. So let's draw some of these out. All right, so macular adherens, I'm gonna tell you a crazy way I know this, but we'll get to it in the next slide. Macular adherens are gonna be our desmosomes. So they are going to hold on both sides, in between cells, right, like this. There's another name for this is desmosomes. Hemidesmosomes is half of this. As you can see here, it is half of it. This holds down to the basement membrane. This holds the cell to the basement membrane. It is fingers coming up, grabbing the cell, holding it down, okay? Now, what is the problem? Y'all will get into this a lot. Bullous pemphigoid. Okay, so the problem with desmosomes is called pemphigus vulgaris. Don't ask me how to spell that. P-E-M-P-I-I-G-U-S, vulgaris. Yeah. Now, the point I want to make out is the way you could tell the difference, which one's which. The problem with hemidesmosomes, bullous sounds like below, okay? Hemidesmosomes attach the cell to the basement membrane, which is below, okay? So bullous pemphigoid is for below. That is your hemidesmosomes, all right? So you get these bulli, these big vesicles, these big fluid-filled, no, you just call them hemidesmosomes. I don't think there's another name for it, but macular adherens can be desmosomes. You get these big fluid-filled blisters, right? Because the cell, these anchor points for the cell aren't working properly. So hemidesmosomes sounds like below, bullous pemphigoid, get these large blisters. Macular adherens or desmosomes, you get pemphigus vulgaris. So these tend to be wider vesicles, right? They're easy to pop because the pieces on the side of the cell aren't working properly. So you could pop them easier. So as long as you know this and you can identify these, you'll be good. Right, so here we go. Hemidesmosomes, bullous sounds like below, desmosome, there you go, that's how you spell it. All right, cool. So this is how I remember it. Call me weird, I don't know, maybe this helps you. So tight junctions here, right? That's the ones that are top. These are our, what are they called? The macula, no, they're not. They're the zone.
Oh, zonula occludens.
Occludens, that's it. These are like glue, okay? Doesn't let fluid through. Occludens, zonula occludens. So that's our O. This is our zonula adherens, okay? These are more like a tie wrap, okay? These hold the cell together. They're just not going to keep them from separating a lot. So these are our adherens. These are our desmosomes. I think of desmosomes as like a spot weld. It's very strong, right? And it's going to hold the cell together. And then our hemidesmosomes are down here. Again, these are very strong. So the zonula occludens are going to be like glue, can't let fluid through, right? You don't want this transcellular path. I'm sorry, this is paracellular, between the cells. You don't want any fluid going through unless it's governed. All right, adherens are kind of like a tie wrap, hold the cell together. And then desmosomes, I kind of think of them like as a spot weld. It's very strong, right? And then our hemidesmosomes are at the bottom. Gap junctions are just holes, right? Fluid can pass between cell to cell. This is transcellular, between cells, or cell to cell, and paracellular is between the cells, okay? Just a little terminology there. I don't know if I have another picture. No. There is a nice picture, like it's kind of like this, but it shows you all of the all of them lined up. It should be in your notes, so you could say those are the occludins, those are the adherins. You see the desmosomes. It should be in your notes. I thought I had it in here, but I don't. But make sure you can identify those. They always go in that order: occludins, adherins, macula adherins, desmosomes at the bottom. Okay, so maybe so make sure you can identify those, because they'll probably give you the picture with all of them lined up between the cells and just point to one of them. Okay. All right. What are we looking at here? For some reason, I never remember these. I always have to look these up for some silly reason.
I never remember them either.
It's just like, all right.
I know holocrine and autocrine, but that's it.
Yeah. So, all right. Sebaceous glands. What does this mean? Right. So that's like pus, right? Sebum is like pus when you get a pimple. It's at the bottom of a hair follicle. So that is holocrine. Merocrine is going to be sweat. Those are the two you really talk about. Apocrine has to do with pheromones. Don't really talk about that. So holocrine, if you look here, holocrine is going to release everything as vesicles. That's like pus, those dead neutrophils. You pop a pimple. Merocrine is tiny little exocytosis. That's like sweat. Again, apocrine has to do with pheromones, stuff like that. Don't talk about it that much. But holocrine releases whole contents. Yeah, that's good. Thank you. All right, so you can see that those are your sebaceous glands. So as long as you remember, merocrine is sweat, holocrine is sebaceous glands, you should be good. Then we talk about how does it get where it's going. Endocrine, like your endocrine cells release hormones and stuff. That's going to be released into the vasculature, right? Into the vessel, endocrine, into the bloodstream. Paracrine is like paracellular, right? It's between cell to cell. And autocrine is the cell giving it back to itself. Right? Cool. Now, so as long as you know that, you should be good to go for the test. All right. Now term 2 is y'all can wake up. We'll do some genetics. I guess y'all have had Dr. Sobring. He's pretty cool. He's a good guy. He's funny. So y'all will get him a lot the first year or so. All right, so we want to work this out. So I'll give y'all a second. This might be one of the things on the exam you want to use, you want to type out in the little box or whatever, but I'll give y'all a second to try to figure this out. Don't forget it's RNA too, right?
Brady,
I can't hear you that well, buddy.
Can you hear me now?
Yeah.
A little bit. Okay.
There you go.
Isn't it supposed to be antisense strand, antisense?
So we're gonna go from the sense strand. Yeah. So you want to go sense to antisense, then to so it's a two-step process. Sense strand is your original strand. Antisense is your template strand. So it's a two-step process. I made it as hard as I could so that.
That's what I'm saying, because I got a little confused, because sometimes, like, if you're using the sense strand, isn't it the same thing? Like,
don't give it away.
Yeah, he's trying to make this like a third order question.
Yeah, it is. You are correct. Yeah, you are correct. But we're going to do it the long way just to show everybody how it's done. But yes.
Yeah, because you aren't always going to get the straightforward what you feel like it should be on the exam. You're going to get the second order, third order, fourth order questions where you have to pay attention to the stem, because one word can change what the answer choice is. So, I mean, kudos for you for catching that, but
Spoiler alert.
It was on purpose.
There you go. But we're going to do it the long way. So, okay. Yeah. So just to show everybody. Okay, so I think on the next slide. Okay, so sense strand. Okay, first off, when we read this, you always read this 5' to 3'. If they don't give it to you, it's always 5' to 3' like this. Okay, now what do we want to do here? So we want to find the complementary strand. So the sense strand is your original strand. The complementary strand is known as your anti-sense strand or your template strand. Template meaning you're going to use it to make the RNA. So what is our complementary strand? So again, we want to read 5' to 3', but if we lay it out here, so it'd be T, T, A, G, C, G, C. Okay, now, but what's the problem here? It has to go opposite. So this is 3' to 5'. So how do we read this? You have to flip this around. So that's what I did here. You always want to read it 5' to 3'. 5 is your left when you're reading left to right, 5 to 3. So you have to flip it. All right. So then we take this, and like I said, this is our anti-sense strand, or this is our template strand. So now we're going to say, we'll take this, what we just took, and put it right here. And now we want to make our RNA strand out of it. So just like I did right here in red, we're going to lay everything out, C to G, right? Everything there. But instead of T, since it's RNA, we're going to turn them into U's. Now, they will give you this on the test written 3' to 5'. It is not correct. You have to read it 5' to 3'. Okay? So the trick Youssef was talking about is that if you actually work this out, it ends up, because since you go anti-sense and you flip it once, when you go to the RNA strand and you're flipping it again, it actually works out the same. You just change it. So A to A from the original, A to A, you just change the T's to U's. Now I did it the long way just because they could give you the sense strand, they could give you the anti-sense strand, they could work it out. But basically we went 5' to 3' for our sense, which went to 3' to 5' with our anti-sense. So we went back to 5' to 3' with our RNA, right? So what Youssef was saying as well, if you just go straight to that, you can just, from the original strand, you can change, just change it from T's to U's. Now, if that's confusing, just do it the long way, just because they can give you anything, they can give you any setup you want and you could do it. So remember, sense is your original copy. You have to make the template from that, and you do that. And once you have the template, you can make your RNA strand. Just remember, you always read 5' to 3'. Okay? So those just take a little bit of practice. All right, let's try this one. Did I not fix this? Is this supposed to be cytosine? I think this is cytosine. Yeah. Pretend that's C's. So for this question, yeah, it's double-stranded DNA. You have to assume it's double-stranded to be able to answer it. All right, so the concept we're testing here is that C's are always going to attach to G's, and A's are always going to attach to T's, or if it's RNA, U's. All right, so we have 20% now, it's double stranded. So if we have 20% of C, then we have to have 20% of G, correct? So 40% of our double strand is going to be C's and G's, which means that the combination of A's and T's has to come out to 60%. Now, if that's the case and we know that they're equal, that's 30% A's and 30% T's. If we have 30% T's, we have to have 30% U's in RNA. All right. So key being, if they give you one, you know all four, right? 20% of C means you have to have 20% of G. That's 40%. So the other combination has to be the other 60%. Cut that in half, 30% each. All right, easy points on the test. Don't need a calculator or scratch paper. They may give you this one. Piece of cake. All right, so yes, 30%. Remember, whatever a T is going to be a U in your RNA. This is pretty much as hard as they can make it, right? All right, so here again, C's and G's equal, A's and T's have to equal 60 if the C's and G's is 40. Divide by 2. A's and T's will be 30 each, so U's have to be 30%. All right, there it is. All right, let's talk about this. Cancer treatment, including a tumor suppressor gene that has been silenced. What method should the researcher implement to help assure that this tumor suppressor gene will be actively transcribed? All right. So what combination here is going to make it euchromatin, right? All right. So again, we want to be actively transcribing. So what do we want? So let's talk about how we're going to work this out first. What I want you to know is that anytime you add methyl groups to DNA, they're big molecules. They're CH3 molecules. You're putting it on the DNA. So you're methylating it. This is not good for transcription if you put a bunch of big methyl groups on it, right? So anytime you methylate, you're silencing it, okay? Now, the way acetylation works is if it's deacetylated, the histone is deacetylated, it is positively charged. The histone is deacetylated, it is positively charged. Remember, the DNA wraps around the histone. DNA is negatively charged. So if the histone's deacetylated and positively charged, it's gonna, the DNA that's negatively charged, they're gonna bind. So methylation and deacetylation is gonna cause heterochromatin or silenced, right? So this is silenced, which is hetero. Why is it? Okay, again, if we methylate, and this is common, this is a common practice, they use medications in this way to do this, to silence genes. So a lot of times, especially with tumor genes, if you can try to make a tumor suppressor gene more active, you can actively suppress the tumor. So this is a common thing. So methylating the DNA is going to put bulky groups on it, so the transcription factors can't bind. Positively charging the histone is going to allow it to wind up the DNA. If it's wound up, it's not available for transcription. All right, so the question's asking the opposite. We want it to be active. So we don't want it methylated, we want it demethylated. So it's so it is available, right? for euchromatin are active. And then histone acetylation will take that charge off. So the histone is not charged anymore. So if it's not charged, it's not going to bind the DNA. So I think I have some more slides. So again, so again, the answer, demethylation and acetylation. A trick, one of them always has to have the DE on it. So if it's euchromatin, it's going to be demethylated and histone acetylated. If it is heterochromatin or silenced, it'll be methylation and deacetylation. So one's always got to have the DE. All right, but we'll go through it. I have more slides on it in a second. So look here. So if we put these are going to be able to put this methyl group on there. If you have all this bulky stuff on there, you're not going to be able to transcribe it. Here's the acetylation slide. Again, if it's deacetylated, you see it's charged, right? So it's going to be able to wrap up the DNA. If it's acetylated, it is no longer charged, so it's not going to bind the DNA. All right. So this is kind of the, you could star this slide if you know this, you'll get it right on the test. Heterochromatin or silenced is methylation. Yes, DNA methylation and deacetylation, histone deacetylation, right? You're putting these bulky groups on so you can't transcribe it. You're deacetylating it so the histone has no charge. Therefore, it's not going to bind the negatively stranded DNA. Opposites for euchromatin. Remember, either way, the D has to be somewhere. All right, let's look at this one. And we'll take a break in a little bit. All right, so y'all will get into these a lot, but as it is, P53 is a component of almost 50% of cancers out there. There's some sort of problem with P53, and I don't know if y'all have got into this second hit hypothesis. Have y'all talked about that? The whole idea of cancer? No, yes, no, maybe so.
We just went through some of that cancer yesterday, but not super extensively.
Okay, we'll leave it at that. But so as it happens, these two are cell cycle regulators. So they act as tumor suppressor genes. So what they do is, if they are activated, they're going to tell the cell to stop transcribing. All right, if they're activated. So primarily, the retinoblastoma gene is involved, but primarily P53. They're cell cycle regulators. So they're going to say, we're going to stop. Now they stop at this G1 checkpoint right before synthesis, right? So P53 is going to say, right before you start synthesizing or duplicating your DNA, they're going to tell the cell to stop. We have enough, we're good. Now, if there's a mutation here, the cell's going to just keep transcribing, right? You're going to keep making more cells, and that by definition is a tumor. It's cancer formation. I do believe I have a question on the BAX BCL2. I think BAC sounds like a gun, like back, right? So it's apoptotic, it kills the cell. And BCL2 is anti-apoptotic. Back, right? Thug life. I'm from New Orleans. Okay, anyway. So that works for me. Anyway, so P53 is, so it's going to stop the cell. So if there's a mutation there, like in cancers, a lot of times this is the second hit hypothesis, right? This is the idea that P53 can't tell the cell to stop. So that's how you get cancer, this tumor formation. It's key. Nothing is telling the cell to stop. All right, so for right now, make sure you know those. And retinoblastoma, you'll see a lot of times they diagnose kids with retinoblastoma. Parents will take a picture of them and one of their eye lights up red. It's like, what? You know, sometimes your eyes do that. Well, one eye will do that. And then they bring them into the doctor and come to find out they have retinoblastoma. So that's an interesting fact. I put this on here, put a star by this. I don't know if I mentioned this to y'all, but I really dislike memorizing things. So the more things I could work out in my head and understand, the less I have to memorize. The idea is when you're stressed out, the things you understand stick with you. The things you tried to memorize tend to fade, right, under stressful circumstances. So unfortunately, this little table here is something you just have to memorize. They could ask you any sort of these breakdown. So cyclin D has to do with these kinases. Nope, I don't have a slide, another slide. So make sure you know these and what they go with, just these numbers, however you need to remember it. But again, yeah, so like the more stuff you could work out in your head, it may take a little bit longer the first time, but again, you're building a foundation because it gets more complicated from here. So the more you can break down, the more you could teach yourself in the mirror or whatever to your friends or whatnot, the better you'll be. All right. Cystic fibrosis. What is the likelihood that the other child is a carrier? All right, and there's a teaching point here too, so be careful because we're assuming this child is born already, okay? That's your hint. All right, so cystic fibrosis is autosomal recessive, okay? So one child has it, that's this box right here. So we're asking, what's the chance the other child is a carrier? It's very important that, let's say we talk about a disease that's autosomal dominant, right? So 50% chance that the child's gonna get the disease. Each subsequent child is a coin flip. Just because you have 3 kids that have an autosomal dominant disease has no bearing on the fact that the 4th kid will get it. That's with any disease. Each time you have a child, it's independent variables, right? So you could have 4 children with it and the 5th child could be normal. There's no carryover. So each child is independent. All right, so since we know that this child is born, now if they say it's a fetus, it's different, but we know that from here that the child is born. So you can imply that the kid does not have the disease. So this box is ruled out. This autosomal recessive with the disease is ruled out. So then we ask ourselves, what is the chance that this child is a carrier? Well, 2/3, right? 2 out of 3. This would be normal. This would mean they have they're carriers. So it's the 2/3 rule. I put this on here because it's very easy to just look at the Punnett square and forget this point, but you are assuming that this child is born. If it was a fetus, you can't assume that the child does not have the disease, right? And they could give you that. More likely, they'll give you this to test you on the 2/3 rule. But let's say it was a fetus, you would say, what are the chances? You know, we don't know the genotype of the child. What are the chances it's a carrier? It would be 1/2, right? Because you can't assume that the child doesn't have the disease, okay? If they tested the fetus and they know that the child doesn't have it, then yeah, it would be similar to this, yeah. But you have to watch the wording on that. Another thing that tends to happen on tests is that there's like I don't see the not syndrome, like, so you read it and you see it's like a positive, but it actually says not in there. I don't know. So when you do practice questions, make sure you highlight the not because it makes the, these are just things that have happened to us over the years that tend to stick with us late at night. So yeah, don't forget the nots. Right, so we know the child is not homozygous recessive, so there's a 2/3 chance he's a carrier. That is the 2/3 rule. All right, I think this is from Dr. Mpadja, love her lecture. So if you're one of these people that likes this graph format, this is the way you could test whether, you know, you could figure out very systematically whether the child is autosomal dominant, X-linked, or whatnot. But there are easier ways to do it. In my opinion, you could kind of just look at the Punnett square or try to remember them. But we'll get there when we get there. All right, another thing Dr. Sobring likes to talk about is these gain of function mutations. So quick and dirty, which one is it? Achondroplasia. There are two, okay, first off, what is a gain of function mutation? That means genetically something happened to actually give an extra component to it, or an extra, I don't want to say power, but like an extra ability to it, right? So it is kind of tricky, but there are two you need to be aware of. Now, the gain of function is Huntington's disease. They gain the novel function with Huntington's disease. You get these erratic movements. It's called, yeah, a new feature. That's a great way of putting it. You get these new movements, right? They're called choreiform or dance-like movements. They're uncontrollable. They tend to happen. They're bilateral. So you've gained this function. It's not a good function, but you've gained this function, right? Achondroplasia is you've gained too much of this normal function. What this means is achondroplasia is classically dwarfism, right? So you get the epiphyseal or the growth plates close too early. So when those close early, the child stops growing. So it's too much of a normal function. But you could star this. What you need to know is these are the two diseases going forward that you need to know that have gain of function. Okay, loss of function, much more traditional. When you talk about osteogenesis imperfecta, you've lost the function of the bone, the strength of the bone. So those are more common, but these are the two that we talk about as gain of function. All right, a lot of words here. So for these, what I do as you do these, I definitely use the strikeout function when I do these. So I read one, I'm like, that's not it. Read the next one, that's not it. Just because it's a lot of words and you don't want to waste time going back. So try this one. All right, so yeah, this is a cyclovir. So for right now, the drug questions that y'all will get will be like this. These are straightforward definitions, okay? So the answer is B. What does it mean to have a lack of a 3' OH? Well, this means this 3' OH is where that 5' DNA or a nucleotide grabs the, the 3' nucleotide grabs the 5' of the next one. So acyclovir and these drugs that don't have the 3' OH, they look just like the molecule, except they don't have the attach point. So it tricks the DNA. It sits in there and then it doesn't have an attach point. So it stops the DNA from transcribing, right? It stops it right there. There's no attach point. So that's what this 3' OH means. Now, what's interesting is that what happens if a person takes acyclovir that doesn't have herpes? It doesn't work. It doesn't do anything because acyclovir actually uses the viral kinase to initiate this chain termination. It's a great drug, great invention, right? Because if you don't have it, it doesn't work. But since it uses the viral kinase, it probably does give you diarrhea. Yeah, you've heard. Yeah. All right. So yeah. Yeah, so that's acyclovir. So again, these are just basic definitions that you go through. Y'all will get into the drugs a lot more later. One of the tricks for this one, topoisomerase 2, etoposide, E2, topoisomerase 2, etoposide. You can keep those different. So DNA gyrase is basically topoisomerase, but it is for bacteria. So ciprofloxacin is an antibiotic. Camptothecin and etoposide is for is anti-cancer. If you can stop this topoisomerase, you can't properly unwind the DNA. So DNA gyrase. DNA gyrase is one of those ones that comes up like as the cumulative. Zidovudine is AZT. Yes, that's the same thing. DNA gyrase and ciprofloxacin, I think, came up as cumulative, like down the road. So like, note that. They like to ask question. Didanosine, I'm not sure. I think Zidovudine is AZT. That's the first one they came out with, that the movie that Matthew McConaughey's in, yeah, in the 80s. Filmed outside my high school, and I wasn't there at the time, but yeah. Anyway, yeah, but that was about AZT or Zidovudine. Dallas Buyers Club, that's it, yes. Okay, let's do this one. Yeah, for the last question, the analog, knowing the analogs for the drugs, like which one correlates to A's and G's, yeah, that wouldn't hurt to know those for sure. Yeah. All right, so the normal slicing pattern, remember, you have a donor site to acceptor site, always. Donor to acceptor. Now, I have a way, a rule that I do this that will never fail you, okay? So you always go from first available donor to first available acceptor, okay? So this is DA, 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 right? Okay, so we have a mutation in the splice donor site for intron 1. Donor site for, oh, sorry, for intron 1. This is the donor accept, oh, I'm sorry, hold on. Sorry, guys. Messed that one up. You always go from the introns, not the exons. Let me do this one. I have a slide on it coming up, but I want to do it for you. All right, you always go from the introns. So donor of, that's a donor site. Acceptor. The idea is that you're splicing out the introns. Okay, so you have a donor and an acceptor, donor, acceptor. Right, beginning of the intron to the end of the intron. Now we have a mutation in the donor site of intron 1. So remember, the rule is you go from first available donor to first available acceptor. So we're going to walk down the DNA strand. Is this a donor? No, it's mutated, so we can't use it. Do we use this? No, the rule is go from first available donor to first available acceptor. Go here. Does this work? Yes. Okay, cool. We'll cut here. Now, first available donor to first available acceptor. Does this work? Yes. What does that mean? We cut this out. So then the correct answer would be here, right? We couldn't use this first donor, so intron 1 ended up staying in, right? They used to consider introns junk DNA. Now they're coming to find that there's a lot of importance in this DNA. But the idea is that when you make your proper proper mRNA, you're getting rid of all the introns. Okay, so and you could see this is just more for completeness sake that, sorry, hold on. That typically that the 5', this first donor site is usually a GU, and then the end is an AG, right? So that's what you would, and you just cut out from the first donor to the first acceptor, okay? All right, so this is how again, this is how the rule, first donor site to first acceptor site, always. Now, let's practice. All right, so let's say we have a mutation at this acceptor site. Let's go walk down. First donor to first acceptor. Does this work? Yeah, cut there. Now go to first acceptor. Doesn't work. Are you an acceptor? No. here. What does this mean? That means everything in between here is cut out. Okay, so the answer would be exon 1 attached to exon 3. Cool. All right, let's try it again. What if they throw an extra acceptor site right here? All right, walk down, first donor to first acceptor. Yes. To first acceptor right here. Yes. Okay, so you're cut out. Now what do we do from here? First donor to first acceptor. Go, are you a donor? No, you're a donor. You cut to first acceptor right here, you cut. What does this mean? That it'll be exon 1, this little piece of intron is left in, exon 2, exon 3. All right, as long as you follow this rule, you'll be fine regardless of how they set it up. All right, let's try one more. Let's say they put a donor site here, an extra donor site. Walk down, first available donor site to first available acceptor site. Are you an acceptor? No. Acceptor site, cut. All right, so it would be the same. All right, first donor to first acceptor. Keep it simple. All right, and if you want to work on these were from, I think this is pretty much all the possibilities they could give you, but that rule works for everything. Oh, if you use reverse transcriptase, actually good question. Y'all don't need to know this right now, but if you use reverse transcriptase, you're not going to have any introns, which is traditional. That's how you can actually look at that with like HIV and stuff, but y'all will get there later. All right, everybody's favorite, meiosis and mitosis. I have to relearn this every time I talk about it, but okay. We're gonna take a break after this. Yeah, so this one's a little tricky because y'all really haven't got into this too much, but we're talking about sperm formation. So once we get a fully formed sperm, we're all the way down the process of meiosis. Remember, mitosis are going to be just your cells that replicate, like your skin. Anything that has to do with replication or germ cells is going to have to do with meiosis. All right, so once you get a fully formed sperm, we have 23, 1 in, sperm joins with egg, which is another 23, 1 in, which makes 46, 2 in the kid, half from mom, half from dad. Let's look at it. All right, so before we start, you have a cell that's 46, one of each, one blue and one red, right? We hit that P53 checkpoint, it's not active, we get to cycle through. All right, we're gonna duplicate our cells first. So the N represents how many types of chromosomes, all right? So we have a blue type and a red type. The D represents how many copies, the sister chromatids. So there's 4, so 2N, 4D. Now meiosis 1, you're gonna split those in half. So you're gonna get 1N, one type in each, 2 copies in each. In meiosis 2, these split into, the sister chromatids split into gametes, right? These are our sperm, and you're going to go to fertilization. You get the zygote, right? Green be mom, will be mom, or vice versa, whatever. Works out good there. Now we talk about this non-disjunction. This is typically how you form trisomies. So either you're gonna have a problem at this first split point or the second split point. So if you have a problem in non-disjunction meiosis 1, that means all 4 of our sister chromatids went to one side. Now, what does that mean when we go down? Now, this worked properly. We split in half at meiosis 2, but as you can see, you have 2 empty gametes, right? And that's because we had a problem at meiosis 1, okay? And you have 2 possibilities for trisomies here, and these will not be viable. Now, what if we have a problem in non-disjunction? Meiosis 2, meiosis 1 worked properly, then 2 didn't split. So in this situation, you're going to have 1 empty gamete, 1 possibility for trisomies. Now, obviously, tests are not going to be essay format, so how would they ask you something like this? Here's a trick. This is not black and white. This is just kind of something I like to use. Typically, they'll ask you about Klinefelters. This is a man with feminization, right? It's a man because he's XY, but he has feminine characteristics. He'll be tall, he has gynecomastia, he's infertile. But this is what they'll try to ask you. Now, the trick here is if it's non-disjunction 1, you skip the first X in both of them. You have 1 of each, okay? Turner syndrome kind of falls in both, but you have 1, okay? 1X, 1Y, or 1-0 after the first X. I don't know if this works. If this doesn't make sense to y'all, don't worry about it. This is just how I do it. Non-disjunction 2 means after the first X, you're going to have 2 of the same thing. Okay, they'll probably ask you about Klinefelters. They'll give you this whole scenario. The guy has Klinefelters. Is it a problem in non-disjunction 1 or non-disjunction 2? There you go. So if I said for this one right here, whose side of where was the non-disjunction, on mom's side or dad's side? It would have to be dad's, right? Because you can't get 2 Y's from mom. What about this one? Is this mom or dad?
Mom, because you have no Y.
Well, it could be a female from dad. So it's a trick question because you could get it from mom or dad, because if dad gives the X to a female, you could get an extra X. Yeah. So that's a trick question. But the point is that for you to get the Y, you'd have to get it, X, Y, Y would have to come from dad. So this is just a quick way I do it, but that's as far as you need to go for that. What about this one? Can you tell from this? Where'd you get the extra? So you know you had to get the Y from dad. So that means that extra X had to come from mom. So this would be from mom. Okay, because the Y came from dad.
Brady, I have a question. So
sure.
The only time we are not sure if it's from dad or mom is when we have the triple X?
Yes. Well, in Turner syndrome too, because remember this 0 represents an empty space. So technically the girl could have got the X from mom or dad, but yes, that's correct. In that case, in any other case, you would get it. So this would definitely be a female, should be very female, then extra X. You get 2 bar bodies actually, but usually they talk about this set right here. But yeah, so that would be the situation where you don't know. All right, I think.
Thank you.
Yeah, no problem. I think I have, okay. I don't know if y'all had Dr. Trotz yet? Yes, okay, great, she's awesome. These is one of her break slides. So we'll take a 5-minute break and then we'll come back. I can answer any questions y'all have and we'll finish up. All right. I did have a question. So remember the answer choices, there are no A and B are correct, or A and C or all of the above. It's never like that. And technically you could have 2 right answers. They always want you to pick the best answer, okay? Which is tricky, but you have to pick the most correct answer, whatever that's worth. Sometimes, like for example, yeah, it should be straightforward for y'all this time. But for example, they'll give you a drug or something like this, and they'll give you a list of drugs, and you need to pick the first line drug, right? There'll be other drugs that work in the situation, but you need to pick the best drug available. So yeah. So anyway, yeah, we're gonna make the best of the island. We shall party. All right. On that note, let us get started. Now, y'all are gonna get a brief introduction to these pedigrees and these genetic deficiencies. For FTM2, y'all hit it really hard with the different Hardy-Weinberg and stuff like that. So you may have seen a lot of this in undergrad. If not, we will break it down for you. So autosomal dominant, right? That means all you need is one mutant copy. It is the dominant copy that you would get to have the disease. So what you see here in the pedigree is what's called vertical inheritance. You never skip generations, okay? Since it's autosomal and not X-linked, you are going to see equal amounts between males and females, okay? So you can see that male-to-male transmission, the sex of the parent or whatnot doesn't really matter. All right. So yeah, so this is what you're going to look at. So kind of take a snap picture when you do these. You look at this immediately, you say, we're not skipping generations. This is fairly common. You can see equal breakdown between males and females. All right. Now, autosomal recessive, we talk about this horizontal inheritance. You do get skipping of generations. It's a 1/4 inheritance, right? Because you have to have both recessive copies. So when you do those Punnett square, you have to have little a for this. So you do get it, but you get this horizontal pattern. What this implies here is that, and what you can tell without it saying anything, is that both parents have to be carriers, mom and dad, or dad and mom. Why is that? Because 2 of their children got little a, okay? That means they're not colored in, so they don't have the disease. So that means dad here and mom here have to be carriers, because that's the only way 2 kids could get it, both male and female. So yeah, so that's autosomal recessive. X-linked, you do get skipping of generations, and then you have to worry about patterning between sexes. So typically females will be carriers for this because you get one of the mutant copy. Females have 2 copies of the X, so one of the X's is mutant. Now, because males only get 1 X copy, if they do get the mutant X, right, they're gonna get the disease. This is called hemizygous, okay? This is why in X-linked recessive diseases, men tend to have it more often because they only get 1 chance at it. Females can have an X and an X, right? And 1 X is mutant, but 1 is okay. If guys get the mutant X, they have no normal copy to work with, okay? So you tend to see this more. So if we look at this here, we know mom had to be a carrier, right? She was XX, and that's how this guy got it, all right? So you see father to daughter transmission, father having the disease here, to daughter being a carrier, and then daughter being a carrier to son transmission, mother to son transmission, mother being the carrier, son having the disease, okay? And the more practice you do with these, the better you get. Mitochondrial, mom always carries the mitochondrial gene. It's separate, it's a separate genome altogether. So mom transfers it to all the kids. Okay, so you could be systematic about doing these. You can, if you have time on the test, if it's not that straightforward, a lot of times they'll give you, they'll give you the pedigree and give you a list of diseases, right? And you'll have to pick out which one. So you have to tell that this is mitochondrial, and then from the answer choices, you'll have to pick out the 1 mitochondrial inheritance. So it's a 2nd order question. But here you could see mother is giving it to all the kids. Father doesn't transmit it to the kids. Mother transmits it to all the kids, okay? That's mitochondria. Again, this is that same thing we looked at from Dr. Mpadya. This is just a systematic way of doing it. But hopefully, you remember our little mnemonics. So for autosomal dominant, we use man of Ham. These are the ones you need to know. These are autosomal dominant. So every time you have a child, flip of a coin, right? So 50% chance you get it, Marfan's achondroplasia, all of these, right? So man of Ham. So if they give you a pedigree, it shows autosomal dominant pattern. One of these is an answer choice. That's what you want to go with. Autosomal recessive, chap gets cash, all right? That's the one we use. So what you'll see is, let me go back a second, autosomal dominant tend to be structural problems, protein structures such as osteogenesis imperfecta. Achondroplasia has to do with the bones. Marfan has to do with collagen. Myotonic dystrophy has to do with muscle. These are structural problems. This is not black and white. This is just kind of a concept. Autosomal recessive tends to be enzymatic problems. PKU, galactosemia, these are deficits in the enzyme, okay? So these tend to be enzymatic problems. So chap gets cash. Yeah, so it's not black and white. Yeah, so there are some that cross over. Now, X-linked recessive, there is a mnemonic for this. I am not going to say it on a recording. If somebody knows the dirty mnemonic, they're welcome to put it in the chat, but I'm not going to say it. Now, these are the ones. It starts with lucky girls, but that's it. Yeah, I see you. All right, so y'all look that up or something. But yeah, these are the ones for X-linked recessive. Remember, mother carrier is going to give it to the son that has the disease, typically. This is from first aid, and this is what I'm talking about. These are some good little breakdowns. These are some definitions you're going to want to become aware of. Remember, so for incomplete penetrance, so let's talk about these because these are commonly messed up or confused with. Variable expressivity is a spectrum, okay? It says how bad is the phenotypic mutation. So you could find it on a spectrum. You could have it very bad, you could have it mild, it could be in between. Incomplete penetrance, on the other hand, is an on-off switch, okay? So if it's incomplete penetrance, you can have the mutant genotype and not show any phenotype. And so variable expressivity is a spectrum of the disease. All right, thanks, Alyssa, doing work. All right, incomplete penetrance is going to be an on-off switch. So if you look at a pedigree and you see that a person should have it, right, but they don't show any phenotype, that it could be incomplete penetrance. It's an on-off switch. Either you show symptoms or you don't. Variable expressivity says, well, my grandma had it really bad and I had it kind of mild, right? That is variability. Anticipation, this is what we talk about with our trinucleotide repeats, okay? So what happens in stuff like Huntington's disease is the degree at which the onset of the disease is how many trinucleotide repeats. You just copy and paste them onto the end of the DNA. So if dad has 200 repeats and the son has 300 repeats, you can anticipate that the child will get the disease onset sooner, okay? So dad has 200 repeats, he had the disease at 50. The son has 300 repeats, he might have the disease onset at 45. Huntington's is one of those weird diseases where it doesn't show up until adulthood, but that's the concept of anticipation. Each subsequent generation will have more repeats, which means the disease will happen sooner. All right. Codominance, the only thing we really talk about there is blood groups. You're different blood type, but none is better than the other. Let's see what else. Mosaicism is weird. The question they ask with this is, they said a man had children with 2 separate women, and he does not show the disease phenotype, but the children from the 2 different women both show the disease phenotype. That's what they usually say for this situation, and that means he had some sort of gonadal mosaicism, which means some of the cells were mutant and some were not. Okay, so that's the idea of this mosaicism. So it's just different for the gonadal or the germline mosaicism. But if they have anything where it says a man shows no genotype or phenotype, it's phenotypic evidence, but his children from different women had it, then you could think mosaicism. All right, locus and allelic heterogeneity, you want to keep these separate. Allelic heterogeneity means that you can have a mutation on one gene, a different mutation on the same gene. Cystic fibrosis is a good example of this. You can have a mutation at 0.10 or 0.200, and you still get cystic fibrosis. Allelic means same gene, right? Same allele, right? So same gene, different alleles. But you're going to get same gene. So there's also diseases where you can have a mutation on different genes that cause the same disease. Albinism, polycystic kidney disease is an example of this y'all might have come across. So this means the mutation is on different genes. Allelic means it's a mutation on the same gene. And then we'll talk about the uniparental disomy because they love this. Okay, so the process of imprinting is a normal process. That's the first thing I want to get across. So what's supposed to happen is, remember when we add these methyl groups, we're going to silence the gene, right? This is this methylation process. So on dad, let's see, it's down here. So on dad's DNA, you're supposed to silence UBE3A. You're supposed to get this SNRPN from dad. This is the normal process. You only want one SNRPN. Now, from mom, you're supposed to silence the SNRPN and get one UBE3A, okay? This is the normal process. This is what happens in all of us. Now, if there's some sort of mutation or deletion, you can get problems with this process. So let's say, for example, we get a deletion in dad's DNA. What does that mean? Well, first, let's look at mom's DNA. It's doing what it's supposed to do. It's silencing the SNRPN. You're supposed to get UBE3A from mom. But from dad, you're supposed to get the SNRPN, right? But it's not there. So this is going to lead to Prader-Willi syndrome, okay? These kids tend to be overweight and they have polyphagia. They tend to eat a lot. It's very interesting when you see the differences between these two imprinting syndromes. They're almost polar opposite. But so mom's gene is doing what it's supposed to do, okay? Dad's gene, you don't get the SNRPN because if you look back, the SNRPN is supposed to come from dad. There's a dad deletion, so there's no SNRPN. Now, what can also happen is if you get maternal disomy, okay, a uniparental disomy. So you're getting basically two UBE3As, both from mom, okay? So what ends up happening, if you remember, we looked at typically what happens, we looked at the trisomies. So you end up with 3 in 1, okay? So we'll say 1 from dad and then 2 from mom. Well, there's this process called trisomy rescue where the cell says, oh my goodness, we have 3 copies, we need to kick one out. So it randomly kicks one out and it kicks dad's out. What this means is you get 2 copies of mom's. Excuse me a sec. Right? So the same principle here is that you're still not getting the SNRPN from dad. Whether you get a dad's deletion or a mom's disomy, you're still not getting it. Still not getting the SNRPN, so you still get Prader-Willi syndrome. So presentation-wise for Prader-Willi syndrome, it is the same as saying you get a paternal deletion or a maternal disomy. Same thing, all right? Whole point is you get no SNRPN. There is no difference in phenotype. No, there's no difference. You still don't get the SNRPN. So it's my understanding that there's no difference. Now, same thing could happen. Now, what's crazy is these kids that have Prader-Willi syndrome tend to be overweight, tend to have polyphagia. They like to eat a lot. What happens with Angelman syndrome, or if you have a maternal deletion, is you get these very skinny, tends to be girls. Actually, I guess it doesn't matter. They just always present it as a girl. And they call it, I don't know if this is politically correct anymore, but they call it happy puppet syndrome. The child always laughs a lot. There's a lot of mental disability there, but there's very differences in just this simple process. So The point here, I think a way that people remember it, P for Prader-Willi means paternal deletion. And Angel man, the M in man, is for maternal deletion. So what's the problem here? Dad's doing what he's supposed to do. You have the snurpin, but mom does not have the UBE3A. It's deleted, right? So since the UBE3A is deleted, you don't have it. You end up with Angelman syndrome. Now, again, this is the same thing as saying a parental uniparental disomy, right? So we had that trisomy rescue or whatever. So whatever happened, you end up getting 2 copies of dad's and none of mom's. Same principle, you still get no UBE3A, okay? Because dad's doing what it's supposed to. It's methylating the UBE3A. You're supposed to get the active copy from mom, all right? So this is an important concept. It's going to come up again and again. They like to test this concept. Remember, imprinting is the process of methylation. It's supposed to happen. If you get this deletion or a uniparental disomy, you get these symptoms. All right, let's try this one. All right, let's work this out. I don't want to keep y'all too long. Obligate carriers. What does obligate mean? It's saying, what do we know definitively? Who of these is definitively a carrier? All right. So even if I didn't tell you it was sickle cell, which is what? Autosomal recessive, right? Even if I didn't tell you that if you looked at this pedigree, you could definitely rule out autosomal dominant, right? We don't see this vertical inheritance pattern, right? So you're probably thinking autosomal recessive. You probably had to look at it a little better to see mother, if it was X-linked, mother would give it to the sons, and she has it. So likely this is autosomal recessive just on the surface. But now, if it tells you it's sickle cell, you know immediately it is. So that means mom is little a, right? So who's a carrier? So we know, at least from mom, each kid has to get one of the little a's, right? Correct? So this is 2, 1, 2, and 3. All right. So in this situation, we use mom to find out the kids. So we know 2, 2, 1, 2, 2, and 2, 3 all have to get at least one little a. We know dad's normal. So he's A. Now, Dr. Sobering's going to bury into your head the idea that you would always want to assume this guy's big A, and not big A, little a, all right? Just because population-wise, it's much more likely that he's big A, okay? So you can make this assumption. But y'all will get into that a lot more later. So you assume in this situation, he's big A, all right? It's just population genetics. Y'all will do that later on. Just trust me right now. So you get little a on this one. So you know 1, 2, and 3. Now, what you can also do is use the kids and work backwards, right? So you know that this kid is little a, right? This kid is little a. So what does that mean about the parents? Both parents have to be carriers. Okay. So 2, 1, 2, and 3, and 3, 1, and 2 have to be our carriers. Obligate meaning definitively we know this, okay? So that's how you work this one out. What you'll find is that more often than not, they're gonna give y'all autosomal recessive patterns because it's just a good way of teaching this stuff. So a lot of the questions y'all are gonna get, even when y'all do population genetics for next block. All right, let's do this one. These 2 lines, if you don't know, mean consanguinity, means it's at least first cousins. And what ends up happening in this situation, is that a lot of, since you're close to the same gene pool, you get a lot of similar disease patterns, right? Increase in diseases. All right, so what do we know definitively from this? That the box is not colored in. We can definitively say that this is ruled out, correct? Right, because it's not colored in, so they definitely don't have the disease. So again, reading the wording, we want to know homozygous for normal. That is this one. What are the possibilities of that in this person right here? Well, 1/3, right? So 33% should be right. Yeah. So 1/3 chance, because we have to rule out, again, that 2/3 rule. We want to rule out the idea that they have the disease, right? Because they're not colored in. So it's a 1/3 chance they're big A, 2/3 chance they're carriers. All right, try this one. So consanguinity is just, it's just a way of showing that it's more likely that you're going to get genetic overlap. So a lot of autosomal recessive, problems, but it doesn't like factor into the math really that you're going to deal with. Okay, so if I was reading this on the test, I would, 3-year-old, okay, young, developmental problem, evaluation, seizures, frequently inappropriate outbursts of laughter. Now, here's the thing. Stuff like this, they don't just put in there for fun. This is very important, right? If they give you questions about term 2s, if they start talking about a farmer, right? They don't just tell you the guy's a farmer just cuz, right? It's probably some sort of pesticide poisoning. So y'all, so take these, when you start reading these stuff like this should stand out. Significant for facial features, microcephaly, deep set eyes, large mouth with protruding tongue. Gait is unstable. So some of these are not as specific, but this should tell you the only thing I remember ever talking about here is Angelman syndrome. Inappropriate outbursts of laughter. So what is the problem with Angelman syndrome? Well, it's not actually a problem, but what is seen in this situation, this is that imprinting that we talked about. Paternal deletion, maternal problem, you can get this, or maternal deletion, you can get imprinting, or you can get Angelman syndrome, but imprinting is the process. Not only a maternal deletion, but a paternal disomy. Either way, you're not getting the UBE3A. That will give you Angelman syndrome. Make sure you know the SNRPNs for dad, UBE3As for mom, because they could ask you stuff like that. Anticipation, Huntington's, we talked about that. Heteroplasmy, always that means there's some sort of mitochondrial problem if they talk about heteroplasmy. Imprinting is what we said. Locus heterogeneity, remember locus is different places, different genes. OI, you can get that, and mosaicism also shows, or OI also shows mosaicism patterns. This is what I was talking about with the father. A guy has a baby with 2 different women, and you can see that both of these kids are affected. If you see some pedigree like this, it's typically some sort of germline mosaicism. All right. Yeah, and then like another one's normal. So this is the idea of a germline mosaicism. All right. UTI prescribe erythromycin. So again, for right now, when you talk about these drugs, you just want to have a solid definition for what you're talking about. So what does erythromycin do? All right. And it blocks the 50S subunit. So ribosomal translocation. I think there was one specific slide that had all these, but I went ahead and put the different disease, drugs that work as each. But again, it's like the previous question we did on the drugs. They're asking you what is the mechanism of action. Okay. So just keep the different ones. 30S is streptomycin, 50S is erythromycin, amino acyl tRNA is tetracycline. So a good definition for these, and they're easy points. Oh yeah, here's the slide. Right, so basically tells you what you need to know for these drugs. Okay, all right. Suspect the insulinoma. This was briefly talked about. Y'all are going to get into this later. So what happens when you secrete endogenous? Endogenous means your body actually makes it. Exogenous means you're injecting it. So if your body's making endogenous insulin, you have C-peptide. C-peptide actually breaks off the insulin. It's a propeptide, so it's not working. It doesn't fully form. I'm sorry, it doesn't fully function. But once the insulin's active, the C-peptide breaks off. Okay, so you can actually measure the C-peptide levels to see how much insulin you have in the body. Okay, y'all will get into this more in detail, but it was in your slide. So you could see that here. You have this C-peptide here that breaks off and you get your 2 insulin chains. Sorry, it's this green piece is the C-peptide. C-peptide just lasts longer in serum, in your blood. So you can measure that. So if there's some sort of insulinoma, excess endogenous secretion of insulin, you would expect to have elevated levels of C-peptide. All right, prion disease, this came up. So we definitely want to look at this. Prion is like mad cow disease, just in humans. The little particles that form and do not dissolve or break down easily. So, yeah. So what is not, see, here we go. This is one of those things like if you quick on the exam, the not gets skipped. Don't see the not syndrome. All right, so B, C, and D, yeah, scurpy or what is it? Scarpy, something like that, is the infectious form. But what I want to point out for sure is that scrapey, that's it. Thank you, scarpy. Yeah, it's close enough. All right, what I want to point out is the normal form of prions forms this alpha helix structure. When you have the diseased form, the alpha helices change into beta pleated sheets. What layering pattern do these form? Like primary is your DNA template. Secondary, yeah, right. So you form alpha helices, or you form these beta pleated sheets as secondary, and then tertiary, you fold it again on itself and you use hydrogen bonds. Quaternary, you join multiple proteins together or multiple structures together, such as hemoglobin, right? So these are going to be your secondary structures. Alpha helices turn into beta pleated sheets. I very vividly remember this question on an exam. So there you go. All right, allosteric regulation. So allosteric means it has its own binding site, okay? So if you look at the enzyme structure, and it's like this, right? And the product's gonna bind here. The allosteric site is over here, okay? So if something binds here allosterically, it'll change this binding configuration so that this can't bind. This is non-competitive inhibition. It has its own binding site. Competitive inhibition means they're competing for this same site. So allosteric means it has its own binding site. So it's going to decrease the affinity. It changes the structure of the protein. And did y'all get into this really? I don't know that y'all went into this too much yet, but allosteric binding, you could see this sigmoidal curve. Y'all did? Okay. Yeah, so Vmax is going to be modulated by, let's see. Vmax is going to be modulated, like you decrease your Vmax by allosteric binding or non-competitive binding. Let me see what the next question is. Hold on. I thought y'all did this more in the next block, but okay. So Vmax is controlled by allosteric binding. Km is your potency. So you change the Km for competitive binding. I think y'all get into it in a more detailed next block, but okay. Right, so for example, the allosteric binding will change your Vmax, right? It will decrease your Vmax. So you could see this is the sigmoidal curve that we talk about. It looks like an S. But so Vmax is for non-competitive binding, Km is potency, and your x-axis, which is for competitive binding. So DFP is like a pesticide, right? So it is a competitive inhibitor, but it's irreversible, right? Or I'm sorry, I'm not positive it's irreversible. Oh, it binds covalently, so it has to be irreversible. So it's an irreversible inhibitor at the active site. So what is this going to change? Your Vmax or your Km if it's competitive? Competitive is for Km, exactly, right? So remember, let's just make sure everybody has this straight. Vmax deals with your y-axis, okay? If this is normal, this decreases your Vmax, right? Your y-axis. This is your difference here on your y-axis. This is for non-competitive, right? They decrease your Vmax. If we're talking about potency of the drug, we're changing our Km, our x-axis. That's Km, and these are competitive. First aid covers this well. Y'all, this comes up again and again. I'm sorry, I just don't, it's very hard to know. We talk about the same thing so many times, it's hard to know where we stop and where we keep going. So I just don't want to tell y'all too much if y'all haven't gotten to it yet. So just keep that in mind. Non-competitives, y-axis, Vmax, Km is x-axis, and competitive inhibitors. All right. Y'all did have a whole lecture. Okay, cool. So definitely check out first aid. First aid has nice little diagrams of it. And then irreversibles, remember, have to do with covalent bonding, right? They're not ionic bonding, they're covalent. Once it's covalently bound, it's not going anywhere. All right, and this is another thing that's gonna come up again and again, especially with the drugs. So yeah, so yeah, let me point that out real quick before y'all read this. Km is inversely proportional to potency. So if we look at our graph and Km, oh, Jesus, hold on. If we look at our graph, A's here, and then we give a competitive inhibitor, right? So B, so we change this, right? This has a lower Km than this. Lower Km means high affinity and high potency. So they're inversely proportional. Low Km equals high potency. Hope that makes sense. Definitely need to know that. So as you increase your Km, you're increasing, or sorry, as you increase your Km, you're decreasing the potency. So for example, if you give 1 milligram of a medication to get an effect, it's better, it's more potent than if you have to give 20 milligrams of a drug, correct? It's more potent, lower amount, okay? Inversely proportional for Km. So competitive inhibitors, increase your Km, decrease your potency. Oh, sorry. Anyway, try this one. GLUT2 and GLUT4 are used in different organ systems, but yeah, so GLUT2, they do have different parameters, but GLUT2 is for the liver and the pancreas. So it has a high Km, low Vmax, or sorry, it has a high, yeah, low, sorry, I'd have to look that up. GLUT2.
It's insulin dependent, and so it's gonna be
high Vmax, low Km. No, high Vmax, high Km, because it's not as potent. It grabs everything in the GLUT2. And GLUT4 is a high Km because it's very potent because it's in the muscles. Yeah, GLUT4 is insulin dependent. I could put maybe. Can you pull up the thing from first aid, Lindsey? It's on one of the pages. We could look at it in a second to make sure. Yeah, because they're opposite parameters. Because
GLUT4 is insulin dependent, GLUT2 is insulin
right.
independent. It's really, it's just a sensor because GLUT2 is going to pick up everything, and then that's
yeah. So because GLUT2 has low affinity, then we'll have a lower Km, correct?
Right. Yeah, because
okay.
it mops up everything.
Yes,
but in the muscle, you want to have insulin there to say, okay, grab all the glucose out of the blood to get into the muscle. So it has a very low Km, high affinity, because it wants to grab it. Whereas
yes.
grab what's available. Whereas in the liver and the
GLUT4s are muscle, adipose, and muscle includes muscle is going to include skeletal muscle. So GLUT2s,
right.
it's the pancreas and
right. And the liver.
And the liver, yeah. GLUT4s are where you're going to find everything else, and then GLUT1 is the brain, and yeah, and the GLUT3, that's not a big one we talked about. It's mainly GLUTs 2 and 4, and then sometimes 1.
And 5 is fructose dependent, but I don't know if y'all talked about that yet.
You'll hit that hard in term 2. So
yeah, y'all will do that later. Okay, nitric oxide, blood vessels. This is a vasodilator. So what is activated in smooth muscle to produce this secondary messenger? Guanylate cyclase. Okay, so remember GMP correlates with nitric oxide. Adenylate cyclase deals with GS. Also, protein kinase A is GS, and CAMP, phospholipase C, is going to be your GQ pathway. So you could see nitric oxide here is guanylate cyclase. So anytime it's GMP, you're dealing with the nitric oxide pathway. It kind of goes off on its own. Shoot, I thought I had another slide. I really think y'all get into this a lot more detail later, but all right, try this one. So a lot of words to basically ask you what the precursor to IP3 was, which is PIP. From PIP, you can make IP3 and DAG. Here it is. All right. star this slide. You need to know this. You need to be able to whiteboard this out. So two separate pathways, basically. You have the GQ pathway. GQ has to do with calcium and Cs, phospholipase C, protein kinase C, and calcium. Okay, so GQ uses phospholipase C, splits to DAG and IP3. Overall, DAG will increase protein kinase C, IP3 will directly increase calcium. All right, smooth muscle contraction. Anytime you have increased calcium, you're contracting smooth muscles. All right, so use your Cs for that. The pathway here, S is stimulatory, I is inhibitory, but they work on the same pathway. GS, adenylate cyclase, works with C-AMP, protein kinase A. So we use our A's here, okay? There are different, these are for the different receptors, histamine, alpha-1. Y'all will do that later. But if you want to use these, but you definitely need to know all of this stuff. These are secondary messenger systems, which I'll have talked about. Okay, here's another one. Yeah, so for FTM2, y'all are going to start going into drugs, and then y'all will talk about, when we do the review, we'll talk about how you break down the different receptors for that.
This
Y'all
is
are good for
alpha
that.
1, alpha 2, beta.
Yeah, but they get, when they do the drugs, because I have a whole thing on it from last term. Yeah, so what are we doing? We said that calcium deals with GQ, right? The C's. We're decreasing GQ, so it has to be D, a GQ inhibitor, right? Yes. Again, make sure you know this. All right. This was no fun for anybody that I know of. The best way to do this is to kind of look at, this is the best thing I could find for it. The problem is you can use a lot of different tests for a lot of different things, okay? But what's helpful here is the gold standard test is put here in the specific use. So when in doubt, memorize that cystic fibrosis, you're going to use ASO blots, okay? Sickle cell, you want to use RIP-FLIP. Excuse me, restriction length, fragment length polymorphisms. Paternity testing's always simple sequence repeats. So it's just one of those things like you can use a lot. Another one they like, array CGH. Anytime you talk about deletions and duplications, array CGHs. But yeah, I agree with y'all. This is one of those things. It was like, I don't know, sequence the DNA. How much does that cost? Like, just know everything. You'll be good to go, right? But that's not how it is. G-banding, remember, is very non-specific. It's kind of an outside picture of what's going on. Fish is a faster picture. Skyfish is pretty. I don't know how, it's just somebody wanted to show off and do that. And yeah, and when in doubt, next gen is always the newer stuff they do. I think y'all will get a whole like flipped classroom or something about this, where y'all do this. But yeah, I would do practice questions. But when in doubt, know what disease patterns. All right, we're gonna do ASO waltz. By the time we're done with this, you'll be able to get it. All right. So what are we talking about? Cystic fibrosis, right? So what is this? This is autosomal recessive, right? Okay. 1, 1, 1, 2, offspring. All right. So I have another slide coming up. So the answer is C, 3 is a carrier, 1 has 3 is a carrier, 1 has a disease. All right, let me show you how I do this. All right, so big A is normal, little a is the disease, right? So mom and dad are what? They have 1 copy of normal and 1 copy of the disease. So they are both heterozygotes. Okay, so we look at this. So you could say both mom and dad are big A, little a, because the wells are filled in both. So they have some normal, some mutant, right? Now, what does that mean for kid 1, this boy? Well, he doesn't have any normal copies. Nothing comes up here. He only has disease copies. So he is little a, little a. So he has the disease. All right. What about kid 2? He does not have any disease copy. He is big A, big A. All of the well, all of his DNA went to lit up this well, right? So when they tag it with the fluorescence. So he is normal. What does that mean for kid 3? Kid 3 is just like the parents. Some normal, some disease. So he is heterozygous. That's as simple as it gets. Normal, disease, go across and check the vertical patterns. Heterozygous, heterozygous, disease, normal, disease. That's as hard as they'll make it for you guys on the exam. All right. So anytime they give you something like this, that means there's a mutation. Mutation at D508. All right. So that's how you do it. It's different alleles, right? 1 normal allele, 1 mutant allele. So sickle cell, or what was it? Sickle cell? Cystic fibrosis, autosomal recessive. That's what you would expect. All right. Try this one. All right, so we said that large deletions, whenever you see large deletions or large duplications, you're thinking of the array CGH, okay? Anytime there's large deletions or large duplications, you want to use an array CGH. Also, this is the first tier test for any child exhibiting a developmental delay, okay? If you don't know what it is, that's what you use. You're looking for some sort of large deletion. I forget the exact number for it, but it has to be fairly large to do the array CGH. All right, does it say here? Maybe not. So yeah, so array CGH is just a better G banding. G banding is outside, you can't really see well, but you see these are too small. These triplet repeat expansions or SSRs are too small. So again, anytime large deletions, duplications, array CGH. All right, try this one. All right, gain of function mutation, right? So what did we say? The 2 we need to remember, Huntington's disease and achondroplasia are 2 gain of functions. 47, age important, some sort of anticipation, right? So we're probably talking about Huntington's disease. How do you diagnose this? You want to do a PCR, restriction, fragment length, polymorphism, all right? For Huntington's disease, if we go back and look at our thing, sickle cell disease, yeah, but you can also use, I thought there was a different one, but anyway, that's the right answer. What else? Wasn't there trinucleotide repeat? I don't know.
It's on the top.
Here it is. Yeah, there it is. Restriction fragment length or PCR. PCR would work. Yeah, thank you. Trinucleotide repeats. Yeah. PCR and restriction fragment length. I mean, it still is PCR, right? That's how they do it. So, yeah. All right, and then this just kind of goes into how they actually do it. I don't know how terribly important though. So this, I have this in my additional resources. Someone went ahead and made this. This was, so would it only be PCR? Was that not an option? So the way they do PCR is primarily with these restriction link, these little ends that come off. So that's typically how they do it. That's my understanding of it. I don't think it's like it's all put together for PCR, but like ASO blots are different type of PCR. But the general way you do it is with restriction fragment length polymorphism. So like the idea is like these overhangs of the DNA that they cut allow for you to amplify that specific DNA. So when you talk about PCR, primarily you talk about restriction length, rip flip, right? Okay, but these kind of go into a little bit more detail of what they're doing. So this rip flip is PCR, and that's how they do it with the DNA probe. They amplify the DNA of interest, and then they're able to look at it on electrophoresis. ASO PCR is more of what we looked at, this different type of PCR where you look at the different alleles. So I think that's as far as they would go into it. But yeah, so like for this question, PCR, the only PCR on here would be rip flip. But even if they put microarray or the, ASO rip flip or ASO PCR, you would go with the PCR rip flip. Yeah. All right. So yeah, so somebody went ahead and made these, and it kind of goes into them in a lot more detail. And yeah, so that's that. That's all I have for you guys. If you want to take another break, if y'all want to go get coffee or whatever, Lindsey's going to take over and do just some cumulative questions with y'all. I'll try to find the KM thing with the glute receptors. That's what I was trying to do. But y'all take a little break and go get some coffee or something, and we'll finish up real quick.
So how do we memorize everything? We don't, and that's a weird answer to your question, but I'm going to explain myself. You're gonna realize that a lot of these things are very conceptual. And so if you're able to get the big concept of something and really understand it, filling in the nitty-gritty details gets easier because they start to fall into place. So for example, if you are looking at a lecture, do you understand what the lecture is trying to tell you? I'm not telling, it has certain objectives, it has certain concepts that you want to go over. So do you understand that as a whole? Then if you understand the concept as a whole, it makes it easier to fill in all the nitty-gritty details. And so instead of memorizing all the nitty-gritty details, you're kind of putting them in their place within the bigger picture of everything. So it takes away the need for like straight rote memorization. Like I don't go through and memorize each and every individual slide. I think that's tedious and it's unnecessary. And why is it unnecessary? Because a lot of this stuff is really it's fitting into a big picture. And for the questions, you need to know the big picture, but it's not like they're going to test you on every single bullet point on every single slide. And so it does get easier over time. And it also gets easier once you start MSK and especially CPR, because FTM is a lot of random stuff thrown together, or it seems like it's a bunch of random stuff thrown together.
So I could just share with y'all how I do my post reads. So I do it in basically in 2 increments the first time around. The first time I post read, I don't focus on memorizing little details. My first post read is about understanding. Like my goal after my first post read is, can I put up the slides and explain them to somebody, right? Now, I find that less stressful because I'm not stopping and spending an hour memorizing a table. I'm just trying to say, okay, this is why this is like this. This is what happens, right? So then the second time I go through, then I focus on ironing out the small details, right? And memorizing things. Again, it's less stressful because I already have a basis of knowledge that I can go back to when I do the memorization. So it's a twofold process. And then prior to the exam, I go through and make my consolidated notes, all the stuff that I want to make sure I don't forget, the little details and stuff. So I think, as Lindsey was saying, it's all about trying to understand it. The more you can understand, the better your foundation and the less you have to strictly memorize. So that's our goal when we do these reviews. It's like, we're going to try to understand the most we can, and whatever is just strictly memorization, well, that's just what we have to do.
I have 2 questions in the chat that came to me privately. I'm going to answer them for the whole group in case you want to know. So I got asked, how do I whiteboard? So Brady doesn't do whiteboarding, but I adore whiteboarding. And the reason being, you need to be able to organize this information in a way that makes sense to you. And whiteboarding allows me to do that. And so I'm just going to share an example of my whiteboarding for you guys, because I take pictures of all my whiteboarding. So if I'm looking here, I'm organizing, this is from term 2, so you're not going to see this until next semester. I'm organizing information. So like, this is an entire lecture, but you'll notice I don't include like every single bullet point because some of the bullet points are more conceptual, but I'm organizing the information in the way it makes sense to me. And so that I can chunk it where it needs to be chunked. I can group things that need to be grouped together. And so I'm organizing it. I'll make charts, I'll make graphs, I'll do anything that helps me organize the information on a broad level. And then I can fill in the little details over time. And so that's so like here, this up in the right-hand corner here, this wasn't presented like this in the actual lecture. I drew this out and mapped it out for myself because this made sense to me. And and this is probably 2 to 3 slides worth of information that I put into one little graphic for myself so that I knew what it was talking about. So that's how I whiteboard. There's another question about histology. Do we need to know all the cells and structures or just stains and epithelium? Whatever is in your lecture slides, that's what you need to focus on. So I had a question earlier about if they're going to test you on small group material. The answer to that is not unless it is presented in the lecture material. So if it's in the lecture material, then it's only going to be tested to the extent that it's presented in the lecture material. They're not going to go over all of the additional stuff because a small group sometimes, or all the times, it's all the times, goes into a lot more detail than the lecture slides do. So you are only going to be tested to the extent that it's explained in the lecture slides. So that will probably,
And that being said, don't waste too much time on small group, just because a lot of it is supplemental learning. You should get together and do them together with your group so that it is supplemental learning. You could, build upon your knowledge, but don't spend for term 4, we have small group almost every day now. So like you definitely don't want to spend too much time. You want to learn what you need to learn from the lecture notes. But yeah, oh, that's a good question. So I know some people that the way they study, they just answered the lecture objectives. I'd rather, like, I like the way, like, just understand what's going on, because the idea of like just answering questions just is not fun to me. Or not that any of it's fun, but it's very unfun. So yeah, I just try to go through and just understand the stuff. But if you like using the lecture objectives to kind of just answer the questions, the problem with that is some of the questions are very broad. So to be like, so like answering it, it's almost better to just go through and just understand it. Because again,
look at the objectives. I'm not gonna lie.
I don't look at them, to be honest with you.
I don't look at lecture objectives.
It's just 6 slides less you got to look at. So it's fabulous. So yeah, but yeah, because at the end of the day, you want to have a general understanding. So if you're just answering questions and you're skipping over some of the larger concepts, you're missing out on stuff. Okay, let me just share this real quick. So for completeness sake, just since we were talking about it. So it goes into a little bit more detail, but you can see, can y'all see? Yes, you can see it, Lindsey? Yes?
Yeah, no.
Okay. What are you seeing?
Yes, hold on.
Yes?
It went off the screens for me, sorry.
Okay. So look, this is a little bit more detail, but if you know hexokinase is muscle, glucokinase is in the liver. So hexokinase is GLUT4, glucokinase is GLUT2. You don't need to know that, but I just wanted to point out, you can see that in the muscle, you're going to have a lower Km, which is a higher affinity. So the muscle is going to want to grab onto the glucose as best as possible so it could use it for energy. Whereas the liver has a higher Km or lower affinity because it just mops up everything that's available. Okay, so that's just for that, but y'all will get into that again in a lot more detail later. All right, so Lindsey's going to go ahead and go through some questions with y'all.
The title was week 1 cues, but I just edited some questions I already had. So this is all weeks. I have a tip for amino acids at the end of this. Somebody asked me in the chat. So just again, please private message Brady or myself. I'll give you guys about 30 or more seconds for everyone to answer, and then we'll move on. But I just want to reiterate, these are not already on our Facebook pages, so you guys have the chance to answer these without the correct answers in front of you.
We'll compile them after. And also, if y'all have any questions, I know we went fast through that stuff. It's just a lot. We can go back and look at them after. So we'll do that once we finish the questions.
Okay, so pretty much everyone is getting it right. We talked a lot about this at the beginning because there was a little confusion. Cholesterol helps stabilize the membrane in times of temperature fluctuation. And there were a lot of nitty-gritty details, but this is the big idea of cholesterol here. Some people said B. Make sure that you understand permeability. That's the ability of a solute to pass through the membrane. Cholesterol doesn't really have anything to do with that. So it's stabilization of the membrane. Next question. Okay, you guys are getting this one correct. So the answer is 2/3, and this is that 2/3 rule, but I didn't phrase it as the 2/3 rule. So a couple, so 2, 2, and 2, 3 are wanting genetic counseling. Cystic fibrosis is autosomal recessive. So this is why you guys need to know the man of Ham and CHAP, whatever those acronyms are, because you are going to need to know what inheritance pattern each of these diseases fall under. So it's autosomal recessive. So the chance that the father is a carrier, which is 2-2. So their sibling has it, but they don't, which means they are either homozygous dominant or they are heterozygous. And if they're a carrier, they're heterozygous, and so it's 2/3. So that's why that is that. And that's just the slide explaining it.
So this is not for the session ID. This is not affiliated with school.
Oh yeah.
You don't get DES points for this. We do this on our own on the weekend, so we could do it kind of our way, I guess. So we could record it and stuff.
On our own terms.
No rules. There you go.
Yeah. Mom and Dad DES.
Get it?
We're the Brady bunch.
Ha. They're too young to know what that is.
Oh my God, yeah. I put a meme on an SDA slide the other day, and after I did it, I realized that there were probably people who wouldn't get the reference, the TV show reference, and it made me really sad. And it also made me feel old.
They know what the Brady Bunch is. Okay, cool.
Good.
That's cool. That's cool.
Okay, well, you guys are getting the answer right. It's inhibition of bacterial DNA gyrase. What is bacterial DNA gyrase? What's the other name for that? Yeah, topoisomerase. Yeah, you guys got it. Okay, you guys are all getting this. So it's COP2. The way I remember this is it's 2 steps forward, 1 step back. And so interrograde is forward. Oh, wow. So it's COP2. So retrograde would be backward, so it's COP1. There are a lot of acronyms and ways. First aid has a lot of help.
I was going to say that.
It really,
for sure.
really
First aid's the best for stuff like that.
Yeah.
For better or worse, the dirtier it is, the easier it is to remember. So don't judge us too much.
I'm getting a little bit of a spread, which makes me happy because it means I tricked you guys. But a lot of you are getting the answer right. Okay, so before I give you the answer, how many double bonds or how many hydrogen bonds are between A and T versus C and G? So A and T is what? Yeah, it's 2 double bonds between A and T versus 3 between C and G. So if you want a low melting point, you want the least amount of double bonds. So you want the most amount of adenine and tyrosine pairs. And so you have to look through here and figure out which is going to have the most AT pairs. So if you look, we're going to start from the bottom up. If you look at D, 40%, so it gives you AT, and so it's 60% CG. Now, if you look at C, it's 25, so it's going to be also 25T, so it's 50-50, so it's kind of in the middle there. For B, it's 40, so that would 40% guanine, so it's also going to be 40% cytosine. That means it's going the other, that's 80%, so that's 20% AT. So cytosine, 20%, that means it's going to have 20% guanine, leaving 60% for the AT. And so the answer is A. So do you guys understand that? Is there any confusion on that? Okay, I'm getting a lot of yes. Okay, so no, I got one no. Yes, I will explain again. So melting point is going to be based off of how difficult it is to separate the double helix. And so adenine and tyrosine are going to have two hydrogen bonds between them. Cytosine and guanine are going to have 3 hydrogen bonds between them. So it's going to be a lot harder to break through the 3 hydrogen bonds than it is going to be to break the 2 hydrogen bonds. And so a low melting point is going to translate to a high AT ratio. And so what I did here was not really give you the ratio. I gave you percentages of individual bases. So, but because each of them has to pair up equally, you can tell what it is. So cytosine has to be with guanine. And so if it's 20% cytosine, you know 100% it's going to be 20% guanine. So that means it's 40% CG ratio, and then it's 60% of the AT. So that means that the majority of that double helix is AT, meaning it's going to have a lower melting point. With B, that's going to be an 80% CG and a 20% AT, so that's going to have a relatively high melting point. C is going to be 50-50 AT to CG, and so that's going to be kind of in the middle if you're classifying these. And then AT, 40% AT means 60% CG, and so if you were to line these up, the lowest melting point would be A. Yeah, you guys are getting this right. They had, I think, like 4 slides on this one concept. They really want you to understand the concept of actin polymerization. Okay, you guys are getting it. I have some answers slowing down. So the answer is lamellipodia. You guys got this right. So actin filaments, actin polymerization is what is going to propel forward. And so propel forward, it's a movement. So you get actin polymerization for the positive movement. I can't talk, sorry guys. And it's going to move it forward. And that little process that's coming out is called the lamellipodia. Yeah, you guys are getting this right too. So it's going to be A buildup of positive supercoils. So do you guys understand the concept of the supercoils and why topoisomerase is needed? Okay, so supercoils, when you are doing DNA replication, you know, it's a double helix, so it's winded around each other. And so when helicase comes in and it snips a part of it and it starts unwinding it, everything past that unwind point, the helices get tighter and tighter and tighter and tighter and tighter. And so to relieve that tension, you have topoisomerase that's going behind it. So you have topoisomerase 1 and you have topoisomerase 2. One of them cuts a single strand, one of them cuts a double strand. You really just need to know the main difference between the two. You don't have to get like too heavy in on the processes there. But they are going to introduce negative supercoils to counter the positive buildup of positive supercoils. So if you don't have topoisomerase, you're going to build up the positive supercoils, and it's going to be really, really, really tense behind the replication fork. Yes, it makes negative supercoils, but you're going to build up positive supercoils if you're inhibiting topoisomerase. So you're introducing negative supercoils to counteract the buildup of positive supercoils, if that makes sense. Yeah, that's one of those examples of making sure you read carefully, because you'll understand the concept perfectly. You'll have mastered the concept, but they're going to switch it up on you on the exam sometimes. And you really have to read, because sometimes there are a couple words and they're going to change it. Okay, everyone is pretty much getting this right. Hopefully you recognize that positive feedback is going to be childbirth. Positive feedback means that the introduction of a, for example, hormone into the system is going to potentiate the effects of that hormone. So you have more and more and more and more, and then there's an end point. Negative feedback is you're basically making sure, because too much of a good thing is a bad thing. So negative feedback is going to make sure that you don't overdo it in the system. So childbirth is going to be your example of positive feedback. The hierarchy, that is with respect to systems in your body that need to, like preferential systems in your body that need to take over others. So if you're in a certain kind of situation, there's a hierarchy. So if you're running away from a predator or something, your blood is going to go to all of your vital organs, and it's going to be shunted away from, for example, your GI system. Because do you need to digest during a time of stress? No, you don't. And so your blood is going to be shunted to these systems that are essentially going to keep you alive and are going to promote whatever processes are going to help you out of the current situation you're in. So, but you guys are getting this right. It's a tumor suppressor. So please, if they give you a gene, please note it. Know what the gene is, the associated the associated disease, and then of course the inheritance pattern of the disease. Yeah, shock is definitely associated with the hierarchy. Yeah, you guys are getting this too. No surfactant, so it's absence of I'm not going to try to say that word. But the reason I spelled it out and I didn't put DPPC is because I want you guys to know any term they can use to say it. So don't automatically assume that they're going to use the acronym. Don't automatically assume that they're going to use the abbreviation. And if there's a layman's term, don't automatically assume that they're going to use a layman's term. You need to know every way that they could say it. So that's why I spelled it out and I didn't put DPPC.
So just a question, can you go back? So the underdeveloped lungs, technically surfactant it does help with the development, but the process of developing the lungs is when the baby breathes amniotic fluid. Okay, so the lungs are technically developed. It's just you're not making the actual surfactant. So it's just a little bit of semantics there.
Yeah, so surfactant, and you'll get into this a lot more in term 2 in when you, or maybe in CPR 2, CPR 1. Surfactant is going to prevent atelectasis, and atelectasis is alveolar collapse. And if your alveoli collapse, you're not getting ventilation, and that is bad. And so surfactant is going to increase surface tension to prevent alveolar collapse and that atelectasis. And so the reason for the respiratory distress is because that child's lungs aren't being really ventilated. And also it's at 20 weeks. 20 weeks, your lungs are developed. And at 20 weeks, that's when you're going to start getting the surfactant. You guys don't know that yet, but the point is that we're at 20 weeks, lungs are developed. So now why is this baby in respiratory distress? It's because you don't have, you have a very low surface tension. And so you're getting that alveolar collapse, and that alveolar collapse is leading to lack of ventilation in the lungs. Yeah, all of you guys are getting it. What's the disease? Yeah, muscular dystrophy. So you have Duchenne's and Becker's. So this is kind of a typical type of question. You are going to have to identify the disease from the presentation, the patient presentation, but they're not going to diagnose it for you. They're going to expect you to know the diagnosis, and then they want you to know the inheritance pattern. Another way they could show this is that they give you multiple pedigrees, and they can say which pedigree is likely representative of this, the inheritance pattern of this disease. So it is X-linked recessive.
I'm sorry to cut you off. Quick question. How can you differentiate from myotonic and Duchenne's?
Classically, myotonic is more of a generalized muscular dystrophy. We don't talk about it that much, just in genetics terms. Myotonic is autosomal dominant, and it's a different place on the genome. But Duchenne's is the classic ones we talk about. These kids are wheelchair bound by 12. They usually die by 20. They have that pseudohypertrophy of the calf. That's classic for it, but you don't have the dystrophin protein that's not made, and you need that to form proper muscles. So they also use the Gower maneuver. They use their hands to walk. Myotonic dystrophy is more of a clonic dystrophy. So you start to clench up. There's too much activation and tonic contraction of the muscles versus more of a flaccid paralysis.
Yeah, you guys are getting this right. The reason I put this question in here is because I want you guys to understand the difference between all of them, but they're not going to ask you a question like this. How they're going to throw these coefficients in at you is in the vignette. They are going to tell you that a certain solute is going to have a reflection coefficient of this, and that is going to tell you if it's permeable or not. And then you are going to use that permeability to solve whatever they're asking you. So they're not going to ask you about this. It's going to be used to aid your knowledge in answering a question. But you guys are all getting this right. It's reflection coefficient of 0. Honestly, so they love eye cell disease, but they maybe 1, 2, 3.
That's later.
Question. No, they did it in the first. Oh, they touch on it. They touch
Yeah,
on FTM1 and then they get more into it later.
Yeah, no eye cell disease for sure, but y'all get into those a lot more in DM, digestive and metabolism.
Yeah, it's not a big thing.
Yeah,
FTM.
no eye inclusion cell, eye cell disease. That's the one with mannose-6 phosphate.
But eye cell disease,
that one.
that's the very long chain fatty acid one, right?
No, that's Zellweger.
Okay, there was one that's like peroxisome and
that's Zellweger's and Ruffson.
Okay, yeah.
Eye cell disease is where you tag the proteins to go to the lysosomes. So if you don't have mannose-6 phosphate, that is your buzzword for eye cell disease. The lysosomes, instead of going, the enzymes that's supposed to go into the lysosomes that break down stuff get out of the cell, and then you have a bunch of acidic enzymes floating around in your bloodstream, which is not good. Yes, hydrolytic enzymes, right?
Yeah, Tay-Sachs and iCell, they might test you on an FTM1, but the LSDs are not a big thing in term 1 at all.
Buzzword for Tay-Sachs is cherry red macula. There's another disease y'all will talk about later that has it, but when you shine a light in the eye, you could see the macula is red, and that just has to do with the deficient protein.
Okay, so I'm going to annotate here. So we have a red blood cell placed in a solution of 100 NaCl millimolar and 400 milliosmoles here. Now, when we look at NaCl, do we have to convert this? Yes, we do. And so we have Na and we have Cl, so you're going to do times 2, so that's 200 milliosmoles of NaCl. And you have 400 milliosmoles of urea. I didn't tell you NaCl, the reflection coefficient. This is going to be 0. It's going to be permeable and then impermeable, sorry. NaCl cannot cross, urea can cross. So that's just standard. So a red blood cell, unless they specify it, you can assume it's 300. 280 is another one they like to use, but if they don't tell you what the red blood cell is, just assume it's 300, honestly. And so osmolarity, that's the moment you drop it in. So this is going to be 600 milliosmoles. So this is hyperosmotic. And then once it has time to equilibrate, urea, you don't really look at urea anymore. So you're really only looking at impermeant solutes. So you have 200 and 300. So this is hypotonic. So hyperosmotic, hypotonic. Did that make sense for everybody?
Can you explain the hypotonic part one more time?
Yep. So tonicity means over time. So when you are looking at tonicity, anything that can cross the cell membrane becomes negligible in your equation. So let's see if I can undo.
I think maybe to clarify, when you're talking about hyperosmotic and hypotonic, you're talking about the extracellular fluid,
you're
not
talking
the cell.
about this.
So you're talking about what is the fluid around the cell. The fluid is hypotonic, meaning
use it. That was just my.
Yeah.
I know how to calculate it, and I got everything to that point, but right then
Okay.
I said hyper, so I was in reference to
that used to confuse me all the time in college when we used to do these things. I didn't understand what they meant by this because I could calculate and I could get the numbers, but I didn't know where you're supposed to look. You're looking at the solution with respect to the blood cell.
So we could take this one step further. What if they ask you, what are the parameters of the cell afterwards? What is going to happen to the cell transiently, and then what's going to happen afterwards? So the cell will initially swell, right? Because the fluid is, the cell is initially going to shrink, right? Because the fluid is going to want to leave the cell.
Yeah, the water.
And then water's going to want to leave the cell, and then thanks, Lindsey. and then after After then once the urea crosses over, the fluid is hypotonic, so the water is going to want to go in. So the cell is going to transiently shrink and then eventually swell. Okay, that's as far as they could ask you, really.
Yeah. So hyperosmotic, hypotonic, and you will probably get one question on this on every exam in term 1, FYI. So this is just the steps in going through this. Yeah, you guys are getting this one.
Remember the trick I was saying earlier? Like if you know Klinefelter's is X, X, Y, you have one of each. I don't know if y'all remember that one. That's how I do this.
Yeah, so it's meiosis 1. You guys are getting this. So someone asked if chloride can't cross, why is its reflection coefficient 0?
I think I answered that. Yeah, so if the reflection coefficient is 0, then it's going to cross. The reflection coefficient is 1, it completely reflects.
Yeah.
It's different from the it's exact opposite of the permeability coefficient. If the permeability coefficient is 1, it's going to be completely permeable. If permeability constant is 0, it's not going to go through. So a reflection coefficient of 1 is saying the same thing as a permeability coefficient of 0. They're the same thing.
Yeah, I said NaCl was 0 earlier. I misspoke. That was a lapse in my speech, so I apologize. NaCl would have been a reflection coefficient of 1 because it's impermeant. Thank you. I appreciate it.
Lindsey was a scribe. She's going to explain what all these things means for y'all because we love trying to guess.
I don't even notice it anymore. So presents to the emergency department via EMS with blurred vision and severe headache. He has a history of type 1 diabetes, non-compliant with insulin, D-stick. This is just checking your blood sugar. And then that is all of my abbreviations. Yeah, a lot of my questions are abbreviated. Any past scribes? Any past scribes in the group?
Me.
Yay! I loved it. It was so much fun. You're gonna kill soap notes. We just had our first soap assessment.
Soap notes are just how you take a patient history, subjective, objective assessment plan.
Charting.
Yeah, for real.
Yeah. Okay, so this question, I don't even know if people were answering it, but we're just gonna talk through it now. So the only thing you need to know is that when insulin is infused, it's going to be driven into adipose and skeletal muscle. So adipose and skeletal muscle, it's GLUT4. You just need to know that they are associated with this GLUT4. Yeah, you guys are getting this one too. So this is microvilli. This is just a cell specialization, cell wall specialization. And so microvilli are the specializations by which you get absorption across. Yes, these questions will be posted. We're going to add them at the end of the review that Brady did.
When the recording is posted for this will be updated as well. So they'll say it'll be the same file, but it'll be updated.
Yeah, you guys are getting this right. So tissue death, a gangrenous toe. This is necrosis. So cell swelling. Cell shrinkage is going to be representative of apoptosis. And the reason you get shrinkage is because it's an organized cell death. And so as everything in the cell is being broken down, it's shrinking. The reason why this is cell swelling is because you have a damage process going on here. It's an inflammatory process. And so these cells are swelling because it's, I mean, you'll get into this in term 4, but so you don't need to know why right now. You just need to know that it happens. I know this list is probably scary, and yes, you will have questions on the exam like this where you have like A through G, something like that. When this happens to you, process of elimination. Use that strikeout feature in ExamSoft. Some like the term 2s and NB, you have some like intense lists going on there. You guys are getting this right. So the answer here is going to be hemidesmosome. This is at the basement membrane. The reason you know this is because it's a large top fluid-filled blister. Emphasis on the word taut. So this is bullous pemphigoid, and the reason I remember this is because bulls are really stubborn, and so this blister is very hard to shear open. So the other one, pemphigoid vulgaris, I think that's the one. They shear extremely easily, and so I mean there's a reason to that because those are the desmosomes, and it's going to be the apical membranes, or lateral membranes. And the reason they're easily sheared is because the cells, the lateral membranes, they're being held together by the desmosomes. So if those desmosomes are defective, then they're not being held together, and it's really easy to shear. Whereas here, the hemidesmosomes of the basement membrane, it's still kind of holding it there because all of the cells together are holding on to each other. So that's why it's harder to break these than it is for the others. So I wouldn't worry about any of these other ones. The ones that they tell you are the ones they're going to test. So so I don't even know what other specializations, what the other answer choices would match up with for diseases, because we only know what we are taught right now. So. Yeah, you guys are getting this one too. Like I said, for FTM1 especially, embryo is very, very, very minimal. And they focus in on a few things. One of them is going to be this. So responsible for secreting, you think syncytiotrophoblasts. And if it asks for cells, then it would be cytotrophoblast. So making cells, cyto. secreting at Synctio? And this is our last question. Yeah, and you guys are getting this one too. So know the difference of the microtubule arrangement for cilia versus primary cilia. You're going to need to know that. So Cartaginer syndrome, what are we talking about here? Yeah, we're talking about cilia, so it's 9+2.
And remember, when they talk about Cartaginer syndrome, that's when you have the sinus inversus. A lot of times all the organs are flipped. So if they ever talk about the organs being flipped, in a guy, they're usually infertile because of the cilia or the flagella in the sperm. But if they talk about that, it's Cartaginer syndrome. It's classic for the cilia defect.
Yeah, and I had one last slide, just making sure things you need to focus on. First thing, the process of DNA methylation. That's such a small thing in your notes. It's like one slide, but they'll pull a question from it. So don't overlook that slide. So somebody asked me earlier what you should know about the amino acids. Know the ones in the specific group. So positive charge, negative charge, which ones are polar. If they specify something like in a, for example, in an enzyme in the active site, if something about that amino acid will change the active site, you need to know that. Pro versus anti-apoptotic proteins, I'm pretty sure we had like 1 or 2 questions on that. That's the BCL2 thing. So there's an intrinsic and extrinsic apoptotic pathway. You'll have like 1 or 2 questions on there. But big, please know how to tell the difference between Prader-Willi and Engelmann, and then know all the genetic disorders and their inheritance patterns. Like oh my goodness, please know all of the genetic disorders and their inheritance patterns. And you need to know how to identify the disorders via the patient presentation, because they won't always diagnose the patient for you in the vignette. And so you need to do it on your own. And then, like Brady said, and like I said, they'll ask you something based off of that diagnosis.
Okay. I wanted to mention something before I forgot. So for the IEA, the Honor Society still has tutors available, where they're going to run through like middle of May. So if you want a tutor for the next exam, you could get one. The sign up link is on the Scrubs page. So you could sign up. We still have tutors available that are trying to get their points for honors. If you're interested in honors, if you get an A above a 90 next term, you can apply. But if you are looking for a tutor, go ahead and sign up now. They're available until the end of their term. Lindsey's on Dogma. Make sure you join her page. She puts a bunch of good stuff on there. This is access to my Google Drive. If y'all don't have it already, there's a bunch of good extra resources. And again, I put my consolidated notes on there for each exam. So if you want to see kind of just down and dirty what I thought was stuff you need to burn into your brain, it's all there. Okay. Y'all are free to go. If anybody else, I know a few people messaged me, they wanted to go back and look at something real quick.